All right, should we start with roll call?
Sure, I'm happy to handle that. Devin Consagra,
Here.
Adrian Irwin,
Here.
Mark Buckholtz,
Here.
Mike Collins, Stacy Geisler,
Here.
Ben Hoffman, Max Kaiser,
Here.
Lisa Kuzis,
Here.
Linnea Lindsay, Larry Lyon,
I am here.
Chris Pinzon,
Here.
Leslie Sutton,
Here, I apologize. My video will be on momentarily. I'm just finishing up some lunch.
no worries, appreciate you. And I heard that Catherine Shable will not be here today. And with that, we have a quorum.
All right.
Do the opening slides.
Yeah, I'm just pulling up the.
As soon as you're ready, Liz, for the opening
Yeah,
slides.
Computer's frozen.
Not behaving, huh?
So just a minute.
There we go. Welcome everyone to the October 10th, 2024 meeting of the Health Evidence Review Commission. I'm Jason Gingrich, I'm Director, Staff to the Commission. OHA has set a goal to eliminate health inequities by 2030, so we want to center our work in that goal today. The purpose of this meeting is to make coverage decisions that will affect over 1 million OHP members, as well as their families, caregivers, and providers. There are no decisions today about individual care. These are all policy decisions. Again, we will be making decisions about coverage of benefits and medical necessity policy for the Oregon Health Plan. Usually we hear public comment, however, no one registered to provide comment today, although we do have, I believe, members of the public observing the meeting. Decisions are not final until approved by this group. They will be implemented at later dates. Many of today's decisions will be implemented January 1st. Some will be delayed a year farther than that to January of 2026. And we'll try to be specific about that. Our general considerations include assessments of the benefits and harms of each service, consideration of patient values and preferences, good stewardship of public resources, as well as just the practical nature of providing coverage in our Oregon healthcare delivery system. Members, please stay on camera and attentive as much as you're able. We understand sometimes we need to go off, but if you do step away, please message Daphne in the chat so we can keep track of quorum. And for those of you online, if you could vote in the chat, and those of you in the room vote verbally, and Liz will record them in the chat so we have a full record of that. Skip the part about verbal testimony. Other members of the public, you can use the Q&A feature to ask questions about that with Daphne. If it's about the substantive discussion, we do require comments to be submitted in advance, but you can email those to us after the fact and we will address them and bring something back to the commission if that becomes necessary. Chat and the Q&A are part of the public record, and this meeting is being recorded and will be posted online. Feedback, there's the email address, herc.info@oha.oregon.gov. If you have anything you want to say to us, that's the place to say it. All right, turn it back over to you, Devin.
All right. We can just approve the minutes from the August meeting. If anyone has any questions or concerns about that at the time. If not, then we just vote to approve the minutes from the last meeting. Anybody not in favor of approving the minutes from last meeting?
Please do put your votes in the chat, though, your ayes. Say them out loud.
Aye.
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 All right, so we can move on from that. And.
Can we get a count on that vote, please?
We have 1, 2, 3, 4 in the room.
1, 2 online. Ben Hoffman has arrived and is abstaining from the vote. Looks like that does pass. Oh, Leslie approves too, so.
Yeah.
Motion passes.
Okay, thank you.
All right, thanks. Director's report.
All right, we have a number of parts to our director's report. And we have a separate item on our benefit update, so I'll skip that for now. One change we've made recently, I just wanted to announce publicly, is that we've been doing increased use of the CMS Open Payments database, which shows financial payments by the medical industry to providers. And that applies to people who testify verbally here at our meetings, as well as our invited experts, providers, as well as the members. And so we try to make that equal opportunity with a threshold of $200. So some of you may have received emails about that. If you have any questions about whether you should disclose anything, please direct them to me personally, or that email address you saw there. And we should give an opportunity for, does anybody have anything to declare today?
Jason, you had sent me something in the email that I had, let's see. Disclosure of interests. Okay, so, and there was something that you had sent me that I had some contact with a Gilead drug representative. So
Right,
there-
and so if that topic were on the agenda today, we'd
Oh,
ask
okay.
you to disclose that, since we don't, that I think we should be okay.
Okay, all right, very good.
But thank you for that transparency anyway.
Yep.
Okay, is that it?
No, I'm sorry, we've got more. We also had a listening session of our Disabilities Health Advisory Panel. Liz, if you could give a brief overview of that.
Sure. We, in August, had a listening session where members of the public attended, gave their feedback on issues that were of interest to them. Many of them were outside of the purview of HERC, such as custodial rehabilitation or wheelchair repair, sort of access issues, provider discrimination issues, housing, ADA type things. So we are working with our liaison, Leslie Sutton, to refine a charter for the advisory panel. All of our advisory panels have a charter. And then hopefully have some more targeted outreach as we plan to go ahead and have our initial meeting in 2025.
Great, thank you. Any questions about that? So that was a commitment we made to the legislature as a part of Senate Bill 1508 negotiations. We had anticipated more topics that might be in the purview of HERC. We heard different things, so we're trying to regroup and decide how to use that panel to really serve the needs of our OHP members in ways that we can actually accomplish here at HERC. So stay tuned, we will continue to provide updates.
And this is Leslie. I just wanted to also say thank you to all the HERC staff that helped with that. We have had some continuing conversations as well about really wanting to value the time and the stories of the people who did come to the session and wanting to make sure that we find ways to plug them into advocacy efforts that matter to them as well. So they can see that as an agency, we are trying to make sure that their comments and their energy is included in health policy in Oregon.
Thank you. We'll make sure we do that follow-up.
Can I ask a question?
Yeah.
Leslie, thank you for that. I'm curious, is the when you say plug them in, is there like someone else from the OHA, like the omnibus office or someone like that who is participating with your meetings, or have you identified someone who can kind of handle those things that are out of our scope but clearly valuable to hear?
I love that idea of having the ombudsman join. I think that that's really a great suggestion. I think we were really, Jessica and I met and we're thinking kind of individually about how to support each story that came up in that way, making sure that, you know, we brainstormed a little bit about where people can take some of that. But I love the idea of coordinating with the ombudsman in these conversations. I think that's great. Thank you.
Yeah, I wonder if this kind of relates to, you know, intermittent earlier conversations we've had about, you know, when stuff comes up and maybe it's not right for this meeting, but you want to get them plugged in somewhere and it's hard to know how to navigate the system and who to talk to and how to make that easier. So maybe that's one way to do it. You know,
Yeah.
Probably making the website easier to figure
Yeah.
out who to talk to and, you know, I mean, all stuff that's out of our hands, but that would be
Right.
useful to, you know, just at a
Yeah, we always do
bigger
our,
OHA level.
our best to do a warm handoff to somebody who can help. Sometimes we're stymied, honestly, but we do our best to do that. And I'll continue to circle back and make sure we close the loop with each person that spoke at that meeting.
Thank you.
Okay, and then Ariel, you want to describe the outcome with hypoglossal nerve stimulation?
Sure. So the evidence-based guidelines subcommittee, their latest topic was hypoglossal nerve stimulation, which is an implanted device that is implanted on the tongue, and then is used to treat moderate to severe obstructive sleep apnea. The center did their evidence review. We discussed that at the EBGS September meeting. There was a lot of concern among EBGS members about the study designs, and they had kind of a unusual study design. And that group felt that because the study designs were really designed in a way that's sort of biased toward good outcomes, that they didn't feel the evidence was really there to cover it. They did hear that there might be some more studies coming, so they tabled the topic for a year. So that effectively means that hypoglossal nerve stimulation will remain non-covered, as well as a procedure called DICE, which is a diagnostic procedure to look at collapse of the airway, which is used before hypoglossal nerve stimulation. So both of those will remain non-covered unless and until EBGS recommends coverage.
Okay.
Did you have a question?
We approved DICE for complex pediatric kids, right?
Yes.
Yes.
There are some
Okay.
surgeries for kids.
Okay.
Yeah.
But it's covered, so-
Any complex
Okay.
kid needs any kind of whatever, yeah.
No, I just remember something, okay.
I may have misspoken. I think we do have some guidelines about that for a general adult sleep apnea. Thanks.
And then we had an errata that came out, and Ariel, you had one other item to add to that.
Yeah, so the errata was in your packet about some coding things that were corrected, and also after your packet went out, we learned that a link in our colposcopy guideline was broken, and we corrected that to the correct link.
Great. And then finally, we had Daphne send out a meeting materials survey to all the HERC members. And that is just about your experience reading, navigating, receiving our packets, our meeting packets, which we know are voluminous. Part of that is to make good use of our staff resources, make sure we're making good use of our time and make sure you're able to access the information you need to make good decisions. Thank you to those who have completed that survey. And if you haven't, I believe Daphne will paste that in the chat now. We welcome additional responses. Part of the reason for that is Senate Bill 1508, which is regarding the quality adjusted life years, included a requirement to redact quality adjusted life years from our meeting materials. Simultaneous but separate from that, there are some digital accessibility requirements coming through, I believe, from the federal level. And when we include external journal articles, of course, we can't control how they're formatted. So we need to think about how we are providing meeting materials that everyone can access and are useful to our members to make good decisions. So we may be piloting a new approach to our meeting materials either in November or January. So stay tuned for that. All right, I think that is all for the staff report.
All right.
We have no public comment on items not on the agenda. Shall we move on to the benefit update?
Yeah,
Okay.
4 minutes ahead of schedule.
All right, hey, we were behind this morning, so that's good.
We did okay this morning.
We caught up.
We were in competition.
All right, so this is an update on what I presented at the last
Hey, Jason,
meeting.
if it's all right with you, I'll call out the page numbers for this meeting too, and this is on page 59 of your packet.
Thank you. And this is the benefit update project. Again, this is the changes that with regard to our federal waiver related to the prioritized list. So go ahead, next slide. So again, CMS ended our waiver that allows us to structure the benefits based on the prioritized list starting January 1, 2027. Although that structure is transitioning, the operational elements of the prioritized list will continue. We will continue the evidence review that happens in this setting. We'll continue to consider code pairings as we do today. We will continue to provide medical necessity guidelines, which really constitutes much of what we do today in the form of guideline notes. Our public processes we expect to remain very much the same. A little legal background for those of you interested in such things. Each state has a state plan outlining its agreement with the Center for Medicare and Medicaid Services. It organizes the benefits into high-level categories like physician services, lab and x-ray services. Some are mandatory, others are optional. The states have more discretion to limit optional benefits. We'll go into more detail on that. There are two key federal rules that we want to talk about today. There are a few more that we won't talk about today. The first one, 440.230C, says the state may not, quote, arbitrarily deny or reduce the amount, duration, or scope of a required service because of the diagnosis, type of illness, or condition. That's not really referring to your work being arbitrary. That's referring to the funding line, which limits coverage based on funding, based on our prioritized list. Our waiver waives that provision for Oregon. Waiver is ending, so that will become force of law governing our Medicaid program. The second one applies now and will continue to apply, and that says that the state may place appropriate limits on a service based on such criteria as medical necessity or on utilization control procedures. Many of the decisions you all make at our meetings fall into those categories, largely the medical necessity one. So we're encoding it on the prioritized list, and that will be going away, but the same decision will be framed in those other terms in many cases, although there will be some exceptions, and I'll go into that in a moment.
So in other words, the arbitrariness derives from the funding line,
Correct.
but most of what we do here really has to do with discussions about medical necessities.
Most of it, yeah. I think the ranking of lines on the list sort of intersects with the funding line, right? That's the interplay there.
Yeah, and although in practice, right, when we vote that we think that something's not medically necessary or the evidence doesn't support it, it ends up being worded as being on line, whatever it is,
yeah.
Which is clearly below the funding line.
Right.
Yeah.
Okay.
All right.
And we'll go into that in a little more detail. So this is just our language from our waiver. I won't read that, but basically, because of what we just talked about, there's no reason to prioritize line 1 different from line 3 or to line 472 or line 658 because there will be no funding line. However, HERC can continue to determine which OHP service is medically necessary and provide medical necessity criteria and policy for some services. So that'll happen much like it does in the funded region today, for example, for knee arthritis, ozone therapy is not covered and does not appear on the funded knee line, while knee replacement does. And that's based on its effectiveness and clinical appropriateness as judged by this group. CCOs can continue to manage benefits subject to the state plan, medical necessity, and CCO contract. None of that is changing. What's changing is the list and the funding line specifically. Again, some of this is reiterating for emphasis because in some ways it sounds like a bigger change than it will be. Our waiver is ending. We will use the state plan to govern the high level parameters of our benefit package. Underneath that, medical necessity policy and utilization management will continue. The state plan will be the high level. HERC and some additional administrative rules will govern medical necessity policies, much as they do today, with the exception of that funding line. In addition, we know that HERC doesn't get into all the different areas, and CCOs have their own policies. They will continue to do that as they do today, approximately the same parameters. Medically necessary state plan services must be covered. Some services will still not be covered because they're not medically necessary or because they're outside that state plan. And as a result of all this, we do expect a small number of additional services to become covered. And I should say this is for adults. For children, EPSDT already applies and all medically necessary services are covered today. So that's an important context. This mostly will affect people 21 and over. Next slide. So the legislative funding line, the ranking, the denials based on the funding line, and therefore the comorbidity rule, which there's no reason for that because it references the funding line, which will not exist. Those will all go away. But, you know, as I've been saying, coverage decisions, denials based on medical necessity, benefit limits in the state plan, code pairings, guideline notes, our public, transparent, evidence-based process, all that's going to continue. Go ahead. This is, I mentioned mandatory and optional services. There's a sampling of those that come up most often in our meetings. There's a link there with a more complete list and citations for the federal rules that are associated with each of those. But you can see the optional services include dentures, dental services, acupuncturists, chiropractors, PT, eyeglasses, hospice. Many of those are covered currently, although there's some unfunded conditions. There are some funded dental lines and eyeglasses lines. Those services are not covered because of budget limitations. We expect the status quo on that unless the legislature would decide to appropriate additional funds for that.
Mark has a question.
Oh, go ahead, Mark.
You're on mute.
Oh, you're on mute.
Jason, quick question on the code pairings and guideline notes. Is that standard with other Medicaid programs as we're changing, or will that be a unique part of Oregon's?
Yeah, each Medicaid program defines its own services. I was just talking to Marcus, who knows from Louisiana, and it's very different there. And so we do things differently here. And so the plan is to minimize the impact of change and continue to do it in the way we do in Oregon.
How do they do it in Louisiana, just out of curiosity?
Can you narrow it down a little?
Very differently, I
True
think you're
science.
saying.
So, we don't have a prioritized, I say we, I don't work here anymore, but we don't have a prioritized list, number one. Number two, because we don't have a prioritized list, we don't really organize our services at the level of the diagnosis. So we think about them in terms of procedures, devices, and then within that, what's covered and what's not covered. So
Gotcha. So they're not paired with the indication, really.
we don't do, so that's like another kind of aspect that's slightly related, but not totally overlap, which is we don't do a lot of procedure diagnosis code pairing historically in Medicaid. Some of the MCOs might, but even that is more limited than what you all do. Certainly the state, we don't supply procedure diagnosis code pairings to the MCOs. Yeah.
Right. one of the reasons we want to retain this in Oregon is we have 16 CTOs. And we want some level of consistent determination across that, and we want Oregon to have a strong value, not just that these decisions are across their health authority on transparency and open decision making. And so that's part of the reason that we do that. Good question, Mark. Thank you.
Yeah, no, thank you. And transparency, Oregon is the only Medicaid program I'm really well familiar with, and so it seems to work well.
Yeah, as we researched this project as staff, it became quickly apparent that states have a lot of leeway to do things in many different ways. And so it's just like when you go to a foreign country, things that you thought were just the way things are done are not the way things are done in other places. And that can be true at the state level as well.
Got it. Thank you much.
All right, next slide. All right, this is a little bit more of a wonky slide, but it shows more of the mechanics, nuts and bolts of what the transition will be like. The unfunded region there is in green. That will be where we'll need to focus our energy over the next year. Those are the services in the unfunded region. Some of those will become yellow, newly covered, cost associated. They need to be covered. They are required by federal law to be covered. And some of them are either non-covered because they're excluded from the state plan, and that's like the dental crowns for adults, like the eyeglasses. There's some other high-level limits there. Others, will be determined not to be medically necessary, which is what Devin was referring to earlier, where we have things, for example, on guideline note 173. They're below the line now. They will likely be not medically necessary in the future. There are some that will need to have a conversation about that here, and that's what we're working. Ariel in particular is working to tee up those conversations. So let's go ahead. So Ariel is reviewing the unfunded region, and also we are still hiring. If you know people, please put us in touch for a part-time medical director position. This is my gratuitous plug. It's a great place to work. But we will be reviewing that. Some of those, in her initial review, some of those conditions just need office visits. Medications, emergency services, no change is really required because they're already covered. Some already have guideline notes. Some there's a clear determination that they're not medically necessary. I think those will be short discussions. Others will require some significant discussion and analysis. We'll need to decide, is there a reason to make a restriction here? If not, maybe it just becomes a covered condition. Others, we'll want to make sure we're practicing good stewardship, providing safe care for our OHP members, and we'll be working through guideline notes and being specific about the code pairings. Prescription drugs, let me finish this and then I'll come to you, Chris. For prescription drugs, those are an important part of treatment we don't deal with directly here, but they are impacted by our work because for an unfunded condition, it can be denied because of the funding line. That is one thing is unique in Oregon versus all other states. So for example, we have some unfunded conditions and you might receive a pain med or a stimulant or anything else, and it might be denied today because of the funding line. That's not going to happen anymore. Therefore, there will need to be a review to say, should that just be covered, or should there be medical necessity criteria placed around that? Should it be prior authorized? Our fee for service pharmacy and therapeutics committee and our CCO pharmacy and therapeutics committee have a body of work for them to complete. To do that, that will be invisible mostly to you all, but it will be going on. With that, Chris? Oh, you're on mute.
Sorry, I had to find my button. This is a really maybe simple practical question, but I'm just trying to envision what that's going to look like, because on that slide 2 ago, right, you have the prioritized list on the left bar, and I've gotten used to looking at the line numbers. And I'm just wondering, is there some thought going into will it now be kind of more in the big bucket categories that you had on that previous page? will there be like an outline format if it's not line items? How do you guys see this being organized?
So I guess I'm gonna answer that a couple different ways. One is the line numbers will become meaningless. So if the line number is 10,042 or the line number is 2, that won't mean anything. We may have some code pairing groups that are specifically not covered, just to make it clear that HERC has reviewed this and does not believe it's medically necessary. So it's not like, did they think about it or are they saying no? You know, those are two different things. But as far as, you know, there won't be a ranking anymore. The other thing you asked about, yes, things might get consolidated. We are working, Ariel's working to do that already. We looked at the ophthalmology lines and there was a whole bunch just collapsed into a single line. You'll see those in the coming meetings, and we'll vet all that publicly. We want to make sure we don't cause any problems that are unintended or create confusion.
Actually, just in my opinion, I think like for ophthalmology, it's gonna improve things because we had multiple lines and things weren't quite right, and working with the ophthalmologist just to kind of condense, you know, this is what we do for this is what we do for that. I think it will actually be, in the end, an improvement.
Yeah, if there's no good reason to have 2 lines, let's have 1. That's kind of.
And we don't know what they're gonna call, I mean, we might call them code groupings, we might call that still to be determined.
We're talking about a code pairings file, I think something along those lines, so.
But I think, if I'm hearing you correctly, Chris, you're asking a question about kind of what's the superstructural organizational framework to.
Yeah, we'll go into
put
that
this
in more
all
detail.
under.
We're still working on that.
Ben is a.
Yeah, Ben.
Yeah, thank you. I'm sorry I'm not there in person. I was hoping to be, but we had some work on the house that needed to be done urgently, and so I needed to be here. I just wanted to bring up the principle of EPSDT, the early periodic screening, diagnosis, screening, and therapy for kids, which that's part of the re-implementation of EPSDT, which had been waived through the 1115 waiver process for the better part of 30 years, is actually the reinstatement of that is part of the reason that the work of the HERC needs to be different. And I just want to make sure that we're thinking about, I mean, EPSDT only applies to Medicaid eligible youth, young adults 21 and under, so kids and young adults. And it specifically requires that any that a state is the state is required to furnish all Medicaid coverable, appropriate, and medically necessary services. And so the principle, the whole idea of a line in the is completely incompatible with EPSDT. And I want to make sure as we're thinking about this and as we're going forward, you know, that the EPSDT does not apply to adults. It only applies to people under the age of 21.
Right.
And so we're going to need to separate out things that impact kids, especially in light of Statement of Intent 4, which is in the 1115 waiver, which says that anything, the least costly, most appropriate services or therapy that will allow a child to grow, develop, and attend school. So I just want to make sure that what you're talking about is going to impact adults, but it's going to it has to differentially impact kids.
Yes, that's correct. So yeah, EPSDT, our waiver ended a couple of years ago. This change technically did not impact kids. That said, we met with a group of allergists and they said, what's EPSDT? And a major condition, there are lots of unfunded allergy lines. They were not aware of that. And we're guessing they're not the only ones. So there will be some impact on children, but it shouldn't impact children negatively because it should actually simplify things and make them more consistent. It will not, this project is not EPSDT for everyone. There are some differences. And one of those differences is that EPSDT allows any medically necessary service that is eligible for Medicaid at a federal level to be covered. Whereas for adults, it will be constrained by the state plan. So those limitations on eyeglasses, crowns, root canals, for example, will apply to adults because those are in the state plan. Those are budget limitations. Those are optional Medicaid services. Within the scope of the state plan, you know, it'll be more similar, but there are still some additional requirements. Some federal and actually some that have been done by the Oregon Health Plan to require a certain kind of review. And I'll get into that more next month. I was trying to work on a slide for that yesterday and it got more complicated quickly. So we are working on it, we are aware of it, and we will continue to share information and prepare messaging about that.
Thanks for bringing that up, Ben. But just to summarize, and to reflect back to everybody, if I'm hearing this correctly, this change for HERC actually brings the process for adults closer to what was already in place for kids.
Closer.
Yeah,
Yes.
except for the exceptions that you're
Well,
talking.
again, stay tuned. Let's go into that when I can speak with more authority and precision about all the similarities and differences, but yes.
On a basic scale, they're both now based on medical necessity and not on
Yes,
a prioritized list, which is the
yeah,
kind of
fundamentally, yes.
Gestalt approach is now going to be similar for kids.
But there will be medical necessity policy for adults. There will be medically
Yeah.
necessary policy for children.
Right, I mean, what makes something medically necessary for a kid versus adult is gonna necessarily differ because the outcomes of interest,
Exactly.
differ, but the process is still the same, it's just what you call an important outcome.
The process is the same from a clinical standpoint. From a regulatory standpoint, there are different requirements. And that's the part that's largely different. I don't know, Ben, if you want to add anything to that.
Okay, I guess I'm still confused about that.
Yeah, well, please hold on to
All right,
that. I
all
hope
right.
to have more for you in November.
I'd just like to ask Ben the name of that regulation again for, the minimal medical interventions to keep kids in school or allow them to get into, stay in school. What was that?
So in the 1115 waiver, they laid out a set of guiding principles
Yeah.
through statements of intent, and it was statement of intent 4 that said that anything that medical necessity will include things that will allow children to grow, develop, and attend school. I'll find the exact wording and I'll put it in the chat.
That is the exact wording, and that's actually a HERC guideline we did even before the waiver ended, because this body decided that was important to do.
I think it's in the EPSDT OARs
As well, yes.
Yeah,
that kind of
it
exact
is.
wording.
The language people seem to like the language.
Yeah.
And I don't see a reason why that would change at this time.
And then just one more follow-up with that, more of a statement would be, a lot of times those medically necessary supports are necessary at school to be able to have a child attend school. And
There is a whole
there's a
policy
breakdown.
realm
So
about
I'm just-
schools and
yeah.
healthcare. We're not gonna get into that
Yes, I
today.
know. I just wanna put it there. I just wanna put it there.
And relative to that, there was guidance that came out this year from CMS specifically around Medicaid billing by schools, not necessarily just for school-based health services. And there's a tremendous amount of interest and a lot of work being done at the OHA maternal child health level around implementing that. That's a
Okay.
separate issue.
Great.
Cool.
We like coordinated care. Sensible government interactions in all schools. Okay, so. Yeah, I already talked about crowns, root canals, and dentures. Again, those we expect to be unchanged unless the legislature comes up with some more money. We do expect a budget impact because there will be some additional medically necessary services that are currently in the unfunded region. Rates will be actuarially sound. We'll follow the usual rate making process. There will be no cuts in benefits. I don't think I said that earlier, but nothing is being taken away from OHA members. Now, we'll continue to do our review and decide something is not medically necessary, then that might be taken away, but not because of this project, it would be because of changes in the evidence or the judgment of this body. Go ahead. For our HERC work, we expect things to continue very much as they do today, other than, you know, the deliverables and the line numbers and things some names will change more than the work will change. We think the values that you all use to make decisions should hold up. We are scouring that and analyzing it from every angle we can. And we'll bring more clarity about that as we move forward. But at this time, I don't expect constraints on this body's decision-making to change substantially. This is a timeline for the project. It's in the packet for your reference. I won't go into detail. You can see that our work is largely, we're supposed to be done by the end of next year. So fasten your seatbelts. We've got a lot of ground to cover, and Ariel is doing her best to make that as simple and digestible as possible. That's one of the reasons we're hiring. We're also looking to hire an additional evidence contractor. And so all of that together to make sure that we make the most important decisions, first, and that we err on the right side where we don't have time to get to something. So we're going to do that proactively. Chris?
This is totally random question because it's my first term, so I only know that we have the tube subcommittees. Would this warrant a third subcommittee, even if it wasn't permanent? It feels like such a big project.
It is a big project. So the way we're planning to manage that is one is meeting with specialty societies. Ariel's got a list of, I think it's 10 or 12, might grow from there, that we're meeting with the staff so that we can kind of, bring proposals that we think are pretty good and limit that. The other thing I'm considering is whether EBGS may take up some of these topics as a first pass, looking for ways to do improvement. The difficulty with the third subcommittee, from my perspective, we may get there, to be honest, but standing that up has some overhead, and then staff has to support it. So we have to make sure that actually result in efficiency. The other thing we can do, again, take the most important topics first and default to cover other topics until we can take time to review them thoroughly. So that's how I'm thinking about it, open to feedback on that. More will become clear as we complete our first pass analysis. Other questions? Okay, let's go ahead. This work will be public, not just in these meetings, several other settings listed there on the screen, including public meetings targeted at members and the larger Oregon community, special work groups for CCOs, because there will be operational implications and of course financial things going on with that will be important to them. We want expectations to be clear. We want a smooth transition. We want people to be aware of these changes. And then updates, of course, at our quality and health outcomes meetings, as well as our public meetings here at the HERC. If you have questions or concerns, there's an email address, special one, 1115waiver.renewal@odhsoha.oregon.gov. Please send them there so they can be routed to the right people. So it's not just our team. If we get them at our email address, of course, we'll just forward them on. But they do some special tracking there. So that's the correct place to say it. So any additional questions about that project? Or comments, feedback for our team? Great.
There's a question in the chat for what does BUP stand for? Again, please.
Benefit Update Project. And we're saying BUP because pronouncing the word doesn't sound as good as it might.
I keep thinking it's buprenorphine, but
Yeah.
But
it's not BUP, yeah.
It's interesting. I mean, on some level, this sounds very complicated, and on another level, it actually sounds quite simple. In some sense, this sounds like we're simplifying the role of HERC. I only bring that up because, you know, in getting ready for that Oregon Health Forum thing, and I was reviewing, I mean, just the nomenclature and the kind of confusion around all of this seemed to predominate. But as we're talking through this, the basic notion of what HERC's supposed to do seems fairly simple. And I wonder if we want to, you know, just as we move forward, I think it's important at some point for us to have some kind of, you know, mission statement, or, you know, a single slide that, like, this is what HERC does. And now that it's more simple, I think it can go on a single slide, right?
Yeah.
You know, we're here to, you know, kind of determine medical necessity based on, you know, the best evidence and input from, you know, the public and, you know, values and preferences of the public and benefits and harms and all that. So maybe it's an opportunity to kind of simplify what it is, because so much gets lost in, you know, the list and the exceptions and, you know, the dental crowns and all of that sort of stuff. But the basic purpose seems.
Yeah, there's one prioritized
coherent.
list in the world, and anytime you have one of something in a much larger environment, that becomes unwieldy and confusing. So yes, at the end, we hope to be at that stage. Getting there, we need to talk through what's transition, because make sure we.
Right, but there still needs to be some kind of a guiding light for what the
Yes,
transition is
absolutely.
aiming for. And so, you know,
And
anyways, I just encourage us to have something that we all kind of can keep coming back to as the.
You're talking about the values to guide the decision making.
Yeah, the mission statement,
Yeah,
basically, for
that-
where we're headed.
That honestly will need to be in rule, and we'll bring more clarity of that to a future meeting. So you have that for your decision.
And Jason, when's the go live date for the new benefit project?
January 1, 2027, so just over 2 years from now.
Okay.
But you'll start even from this meeting, seeing that we're making changes based on the review. So you'll start seeing acute things that need to be changed right now, soon. And then you'll start seeing other things as they trickle out. But yes, the whole change is 2023.
Got it. I look forward to it.
Yes.
This is
Well,
this is Daphne. I just wanted to make a quick comment on our website, and I'm going to put it in chat. If you want a quick way to describe to people what we do at HERC now, we've written a plain language document called "What is HERC Anyway?" And I'll put that in chat.
Oh, that's great.
And you can post that to X if you're on TikTok if you want.
Are you logged on to that?
Oh, the meeting, okay. If you could send that link out to the members by email as well, Daphne, that would be
Yeah,
great.
sure.
Okay, any more questions about that before we move into our more substantive topics today? Not that
Oh,
that's
and
not
I-
substantive, but yeah.
The other thing I wanted to mention is that on Jason's slide, he was talking about presentations to the CCOs and the open card populations. We're also doing presentations to member proxies and member organizations. Jason and I are part of the outreach team that are doing those presentations statewide. So we're representing you and the work you do well.
Great. Thanks, Daphne. All right, so Bupe, we're done with that. And
I refuse to call it BUP or BOOP. I call it BUP.
We're done with that for today, sort of. We'll qualify that statement a little bit. Go
all
ahead.
right, so BBBS report.
All right, you guys met this morning and had quite a few, as usual, different topics to go over. First, we had our consent agenda. There was a table with codes. Just of note, there was one box missing, and basically, it was kind of along with the staff sort of rationale, moving a code from an uncovered line to a covered line. And then we had several straightforward guideline note changes with no discussion. We also had the BHAP coding recommendations. Behavioral Health Advisory Panel met last week, and essentially they had about 8 coding changes they recommended, and so none of that required any discussion and was approved. There were 4 of the HCPCS codes that are active in October. 2 of them are vaccine codes, and they were added to our preventive services guideline, although they'll effectively be exempt, meaning covered for whenever they're billed. And then there were 2 PLA or proprietary laboratory analysis codes for genetic testing for psychiatric medications that were placed on the exempt file because we have a guideline stating that we don't cover that type of testing. Any questions about any of that? We talked about corneal transplants. In August, you took it out of the solid organ transplant guideline. We subsequently realized that would cause some issues. So it came back. We're reversing the August decision, putting it back in, and basically saying that for corneas, just the generic organ transplant criteria, like being, having all your health conditions reasonably controlled, et cetera, that's all that you needed to do to qualify for a corneal transplant. New discussion topics. We looked at ablation for atrial flutter, which is a type of abnormal heart rhythm. And as a part of this process, I had consulted with a couple of cardiologists, and atrial flutter is kind of lumped together as a very similar thing to atrial fibrillation. And there were some changes that the cardiologist thought we should make to our atrial fibrillation guideline. So the changes that were in your meeting materials, some tweaking of the atrial fibrillation guideline were approved without discussion. We talked about genetic testing for cardiac transplant rejection. There were 2 options presented, and the first option was what the group felt was the desirable option, which would reduce the timing after cardiac transplant for the what's known commercially as AlloMap testing to 6 months from 12 months, and then to clarify that the test called AlloSure is not covered. And that was approved 7-1. We talked about secondary and ill-defined neoplasms. This is our only non-covered cancer line. This is part of our below the line process. Any diagnosis that I could find anything that seemed similar, like if it was a intestinal neoplasm of uncertain origin or something, I would put it on the lines with like intestinal or colon cancer, that kind of thing. There were some codes that were still so vague that we couldn't find any appropriate covered lines. They will stay on the uncovered line. These are things like cancer of the upper limb. There's many tissues in the upper limb. Eventually, those will probably be covered only for sort of office visits.
So this is more of a nomenclature issue than anything else, right?
There are some, we did find some denied claims using a few of these diagnoses. Some of them might be like, we were trying to think of scenarios, like a prior authorization before surgery when you don't really know what, but then you would probably use a mass or something.
But you don't mean like unknown, kind of poorly differentiated cancers, unknown primary, that kind of thing.
So the diagnoses.
So I don't believe
That's
this,
fine.
but
So there were things like so malignant neoplasm of the intestinal tract, part unspecified, malignant neoplasm of spleen. We have splenectomy codes on the non-Hodgkin's lymphoma line, so I moved it there. Mesothelioma of other sites with soft tissue cancers. Poorly differentiated neuroendocrine tumors we put with cancers of the endocrine system. Secondary carcinoid tumors were put with carcinoid syndrome.
Okay, so this is mostly just about consolidating the codes and putting.
Right, but these are all currently non-covered. And so they would allow them to be covered if for some reason. I mean, another scenario that I could come up with would be like a person in really poor health, an elderly person who wants palliative care for something, but doesn't want invasive testing for a more specific diagnosis. But then there are things like malignant neoplasm of unspecified limb, secondary and unspecified neoplasm. I mean, there's some really vague codes that I couldn't even find a similar. So some of them will remain below the line, but most of them will be moved. Disseminated malignant neoplasm unspecified will stay uncovered. And then there was some personal history of carcinoid that actually was moved to the carcinoid line because that actually is used for some treatments for carcinoid syndrome. Any concerns about any of that?
No, I don't think so. Just the only scenario I can think of that would be clinically relevant and can come up is these poorly differentiated metastatic cancers that you don't know where they start. It's unknown primary. So I don't know if there are codes that cover that sort of thing. I mean, obviously we would cover the treatment of that, but I don't know where that sort of thing would fit.
C7A. Yeah, I mean,
And maybe it would just be the provider would just select an organ that is involved and put it under that code.
yeah, yeah,
Because
poorly
unknown
differentiated.
primary is not a code.
Actually feel like that's the same code.
Is it?
I feel like I've seen that, so yeah.
C80.1.
Yeah, C 80.0 is metastatic cancer, unknown primary.
Okay.
And that, yeah, those will actually still stay uncovered. Disseminated malignant neoplasm unspecified and malignant primary neoplasm unspecified.
So I think we would want a mechanism for covering, you know, when you don't know what the primary is. Again, I can't imagine that these patients aren't getting covered in practice, but.
Yeah, so unfortunately, kind of going back to the whole prioritized list, we've put things into specified buckets. So what would you put a disseminated malignant neoplasm unspecified, which bucket?
So, I mean, I'm not an oncologist, right? So I'm just bringing up what I could see as a, you know, clinically relevant sticking point. So probably would be worth talking to an oncologist about what they would practically use as a code in that situation. And maybe it's a non-issue. Maybe they're all using whatever other code, but I think we just need to make sure that there is.
So essentially
also
what I'm
just-
hearing you say is the codes that we're leading on 586, we're gonna have to review them anyway as part of the VP process because they're remaining uncovered.
Yeah.
So I could do some more work. Right now I've put them on an office visit only line, which would allow just office visits, diagnostic tests.
Yeah, maybe in that process specifically for this, you know, unknown primary disseminated malignant neoplasm unspecified, figuring out what code would cover that.
But what treatments would you be interested in having that?
I'm wondering how long those codes last. I'm assuming they do some sort of genetic testing or histopathology, kind of narrow it down and
I mean,
to one of those
when I've
abnormalities.
personally seen like disseminated uncertain, they're so mutated that they don't have any markers anymore.
There's nothing on
They're
the
almost like a
histo that gives
stem
them any
cell.
sort of- Yeah, I don't think we've run into this. There's something in the back of my brain that says there is a funded code that covers that scenario.
Yeah, I've seen this in one patient, so my N of 1, where it was so mutated. but they don't really have a lot of treatments at that point besides palliative care.
That may be true, but we should still have it
definitely
should
worth
still be, there should be still an opportunity for coverage for, you know, palliative chemo, whatever it is.
There's always an option through exception, because you do medical review and that's, they can see all this. But
And
yeah.
Would
something
those
more
patients
streamlined.
also have a funded condition
Well, sometimes these cancers are,
or just so diffuse?
we don't know, I mean, they start out even like looking for markers for sort of organ system and they can't find them. Like, it doesn't have the markers for like swollen skin, brain, it just is got so many.
Yeah, practically speaking, you're not gonna be able to cure that cancer.
Yeah, to get treatments that would be for the symptoms, those, I assume those symptoms could have codes used, and then you could get treatments for whatever kind of symptoms are there.
Okay, but there's about 15 or 20 codes that I couldn't find a home for them. I can look at them again. So you can approve the changes were all movements.
Yeah.
They were all moving a code to a covered line. The codes that aren't changing, you can direct me to go back and do some more work, and I'm happy to do that.
Yeah, I think just that one example, but otherwise I think sounds okay. Unless there's have questions or concerns.
Well, and even looking at this, like there's some like undetermined malignancy in a lymph node. I was thinking we wouldn't know where that came from, but we could put that under like a lymphoma. But I don't know if it would be a lymphoma because it might be metastatic from breast cancer, colon cancer, whatever.
But the diagnostic test would be covered, right? No matter
Well,
what.
diagnostic covers.
Yeah, so you have a
'cause the
lymph node that's
diagnostic-
swollen,
So they can
you know,
evaluate it.
surgical
Mhm.
removal of the lymph node, the pathology, that's all diagnostic.
Right.
Yeah,
If they can't, but sometimes the pathologists will literally come back with, we don't know,
Mhm.
it's cancer of
Yeah,
unknown primary, basically.
but still, that still comes back to this.
So-
We just need something, we don't know where
Would
it
it-
came from,
would
cancer.
it ever be the case you would want to try radiation therapy if you have a mass and you just can't figure out what it is?
No, frequently we do,
Yeah.
and I think that would fall under our palliative care guideline. So you have cancer all through your abdomen and
Yeah.
part of it is obstructing an intestinal, you know,
Yeah,
area, they
Yeah.
might radiate that, they might do just some sort of chemo to see if they can get it under control, they might operate to remove the obstruction.
and so that would be palliative, that would be considered palliative, I mean, because it's
It's
not-
generally
we
considered
curative, so-
palliative, it's not curative,
it's for a short term. Sometimes-
right, but I mean, like a bowel obstruction is a
Yeah,
horrible
yeah,
thing, so you don't
yes.
wanna,
That is life.
or life extending and quality of life improving.
Yes, Okay.
But, so, if you're, I think you guys can all be comfortable approving the changes as BBS recommended, because they're all moving codes to a covered line. And I will take back the uncovered ones and look at them a little more deeply.
Sounds good. Yeah. Yeah, thank you.
Now I have to go back to where was I? Impella, this is a device for, hertz. And it has, some people have PTSD from this. Dr. Bob Huber gave us a very nice presentation about a new study, what is it, the danger shock trial. I love trial names.
they called it danger?
Yeah, it was Danish and
Oh.
German, it's different danger, yeah.
I see.
Danger shock, and then what was the other study that was stopped?
Recover for.
Recover for, yeah.
Yeah.
So anyway, we have a guideline about Impella and it allows use during high risk cardiac interventions, but also allows use for cardiogenic shock, which is when the heart's really impaired after an injury. But only as a bridge to either transplant or LVAD. The danger shock trial showed an improvement in mortality in the group that got the Impella compared to the group that got usual care. There were some concerns about the study and its outcomes, but the general sort of conclusions in the research and medical community is that it's a standard of care now, and they actually stopped another trial that was going on because you don't want to continue to do a trial on something that is now, should be used.
Mhm.
So given those limitations, we changed our guideline note to basically say, we cover Impella for cardiogenic shock and removed all of the restrictions.
Yeah,
Ariel, that's great news. I've used it for cardiogenic shock in the ICU on a child. It's a wonderful device.
Right. Yeah, and this is unfortunately an incredibly sick population with a really high mortality rate, no matter what intervention you use.
right. So as I recall, a lot of this wrestling with this topic was carving out all these exceptions. But the big concern was this expansion of use to basically patients with, stable angina, indications.
Cardiogenic shock is,
Yeah, so that still falls within this carve out of, urgent serious conditions.
with a few other options. All right, so we talked about the bone marrow transplant guideline. We currently don't have a guide. We have a solid organ transplant, but not bone marrow. There's a temporary rule with bone marrow transplant and stem cell transplant criteria that are extremely out of date. The rule was basically written in the 1990s. So there lots of things in there that are absolutely not standard. So OHA asked that we have HERC approve a bone marrow transplant guideline so that they can write a rule consistent with it. I brought the staff recommended guideline. VBS had a few concerns. The recommended guideline didn't include some of the things that are in the current rule, or staff had not addressed a few of the things that are in current rule, such as the number of matches between the donor and the recipient, things like that. So staff were directed to work on this a little more, and you'll see revised guideline in November. Trigger point injections, similarly, these are injections that are done into painful muscle spots. There was some request for staff to work further on the proposed guideline, put in a definition of what a trigger point is based staff were instructed to look at the CMS definition.
Sorry, Lynn, we are on page 75 of the PDF.
And there was also some consideration that the evidence is very, very weak and is really just for acute trigger points rather than chronic. And so the staff recommendation to put the trigger point injections on a covered line and a non-covered line, the VUF members felt that it would be more appropriate to leave them on the non-covered line with the guideline to kind of guide exceptions. And we'll bring that back for further discussion.
One thing that I was gonna say, so I could maybe add it to the mix that you can bring up is the requirement of a 50% pain and functional improvement. Between, and I saw that was from maybe some other healthcare guidelines. But I'm wondering if the language of like minimally clinically meaningful improvement or that kind of thing, because that's it could be that's a standard. It can be identified for whatever outcome assessment tool that's being used. So anyway, I was just gonna.
Yeah, I'm just trying.
Sorry, I gave the wrong page number earlier for those trying to follow.
Like 146 is
What?
where I'm.
Yeah, 146. Okay, thank you.
Yeah, I don't think that's written for any change. I think it's written for a certain amount of significant change. That's 50% both pain and
50%
functional.
is kind of huge in the pain world. 50% reduction.
So that's from the CMS guideline. If you compare it to
Okay.
things like the facet one, that's actually low. So those are 60, 70, 80. The 50 is actually pretty low in context.
Yeah, okay. All right, well, fair enough.
Larry, you got a question?
Yes, I do. I'm having a lot of difficulty following along. So I'm trying to, if someone could, whatever page we go to, if someone could just say, we are now on page, otherwise I can't follow along.
All right, we'll get the.
Yeah, we are on page 147 now.
Okay.
Sorry,
Thank you.
Daphne was having some internet difficulties.
Any
Is that why
other?
the screen's not updating? Was that the? Because I usually just follow along with what's on the
The,
screen.
the screen is updating, but I'm also looking on
Oh,
on
yeah.
another screen for additional materials because whoever is running the screen is jumping back and forth. And I can't read it if it's jumping back and forth. So that's why I want to have,
Okay, so we'll just ask Ariel to call out the page number she's on when we go to a new thing.
I mean,
great,
and
I was-
also
thank you.
Ariel is covering a lot of ground in 20 minutes over the course of 5 hours, so, you know, we're just kind of getting through the packet.
Yeah, Larry, is there something you wanted to revisit?
No, it's just I would like to be able to follow along and sometimes I'd
Absolutely,
like to
okay.
read a little bit more while whoever is presenting is talking.
Okay, so page 147 is where we're at right now.
Great, thank you.
Okay, so, Lisa, I added your concerns to my bucket of notes.
Okay, thank you.
Are we ready to move on to deep brain stimulation for dystonia? Okay, this is so dystonia is a
So
severe.
what page are we?
This is
now?
147.
This
Sorry,
is
we were on,
Okay.
yeah, before that.
So this is dystonia is a severe muscle contraction and it can cause functional problems, pain, disruption in sort of quality of life, et cetera. We cover medications and botulinum toxin injections. The request was from multiple neurosurgeons that we consider deep brain stimulation for dystonia. And based on the evidence in other pairs, we agreed. So the proposal that we didn't really have a lot of discussion, it was basically to add deep brain stimulation coverage, which it's a friendly amendment from what was in your packet. There was a bunch of codes that need to go on the dystonia line, which are the CPT codes for the placement and revision and testing and things for the generators and the leads for the deep brain stimulation. And then there are currently 3 deep brain stimulation guidelines. So we're actually merging the 3 guidelines into one and adding the dystonia indications. So 2 guidelines will be deleted, but they've been memorialized in the combined guideline. Any questions about that? We talked about calcium pyrophosphate deposition
That's page
disease.
170.
This is a condition that used to be called pseudogout. There are effective treatments for it, including medications and steroid injections, so it was moved to a covered line. Any questions?
Just a second, okay, there we go.
Anterior segment aqueous drainage devices. What page is it?
That is page 171.
These are devices for treatment of glaucoma. We have a guideline that is very out of date and actually only refers to one brand of this device. And so the recommendation that was approved was to just delete the guideline. It's not pretty standard of care. Any other questions about the new discussion topics? Anyone want me to go back and touch on anything? Then we had biennial review topics. I warned you that you would be hearing some of
So
the
that's
BUP
page
stuff.
174.
Some of this actually came up as part of the BUP process, and things that staff identified that were either urgently needing change or could easily be done earlier. The first one actually is not BUP. This came to us from our pharmacy and therapeutics colleagues. They wanted us to delete our proton pump inhibitor guideline because they can much more rapidly update indications and things and we're trying to get out of the medication world, let them handle it. If we don't have a PPI guideline, there's no need to have the lower GERD line. So the proposal was to delete the PPI guideline and then the lower GERD line will be struck out for the January 2025 list, that it will show up on the list as just crossed out, and then it will be deleted for 2026. There were a couple of diagnoses on that line that double GI bleeds from GERD, and those were moved to the GI bleed line. Any questions about that?
I don't think so, just so I'm understanding. So what if you have, refractory GERD, necessitating a fundoplication or something? Is that?
That should be on the upper line.
Okay, I didn't understand the difference.
Yeah, so our upper line would be for, things that would need surgical repair or
Okay.
long-term PPI therapy.
Gotcha.
But the diagnoses are the same,
Okay,
mostly. Like I said, there's the esophagitis with GI bleeding, needs to go on GI bleed line.
yeah,
And then the diaphragmatic hernias were put with the other ventral hernias and things. That's,
Wait, where did we get, where are you now? We're on hernias now?
no,
Well, still GERD.
GERD, oh, it's part of the GERD, okay. Thank you.
different kind of thing.
any other questions about the GERD? Shoot. Anal fissures.
All right, that is page 213, where it starts.
So anal fissures are small tears in the delicate tissue around the anus. We currently, the both acute, which would be acute and chronic. So acute is that it's been there for less than 6 weeks. Typically it's from trauma, a really hard stool or other, trauma. Typically responds well to either topical medications or treatment of constipation, those types of things. So we effectively think we're covering it now because it's typically something that presents to a primary care office. You're given advice or possibly a topical medication. Those should all be covered. Chronic anal fissures have a different pathophysiology. We think that they're from more of an ischemic or lack of blood flow process. They can respond to conservative therapy, just like acute, or sometimes they need botulinum toxin or surgery. So the proposal was to move both acute and chronic anal fissures up to the anal fistula line with the diagnoses. It said they're actually were pretty much the appropriate surgeries. We added one surgical code to that line for the Botox injection. We modified a couple of guidelines that were pretty minor, more like the line they were applied to. The old chronic anal fissure line didn't indicate that it was
You want these
conservative treatment, it just said treatment. And then the chemo denervation line is just a simple change to reflect that we moved this to a covered line. And so we already had the uncovered criteria after the botulinum toxin. And then for January 1st, those two lines for acute and chronic anal fissure will be crossed out, and then for 2026, they will be deleted.
And Ariel, what's the definition of conservative treatment? I saw that. I understand that would be anything, is it anything non-surgical?
Yes, so my definition, I think what the standard medical treatment would be is dietary advice, laxatives, topical, nitroglycerin topically, and calcium channel blockers topically were the two that came up in the literature review. Sitz baths, those types of interventions.
Okay, but as written, it's pretty much most anything non-surgical, so it seems fairly nebulous in that condition A, that it will be mostly everything, correct? I mean,
Yeah, how specific do we have to be about conservative?
Well, is there something you're concerned about overutilization of?
no, I think from a UM standpoint, if we get this, folks are going to ask us, what is the definition of conservative? Because providers will put, was on laxatives for 6 weeks or 8 weeks or something of that nature.
Gotcha.
And so they would then say that that is a chronic anal fissure and needs surgery for six weeks of Miralax.
In other words, they may be getting passed on for more advanced treatment without really having done a real adequate trial of conservative therapy.
That would be my concern, is that you may get surgery much earlier without an adequate trial of really good non-surgical treatments.
So what we can do is we can table this topic, and I can reach out to my colorectal surgery colleagues and just make sure we could put what we've done in the past, when we've had something like conservative treatment, we'll have a for example. We don't require, well, I can ask them, you know, does it have to be laxatives plus topical medicine plus something? Does it? Yeah, I can ask, and this guideline was written in like 2002. Something like that, so I have nothing to do with the original guideline. But I can take that back. You don't have, we can take that out of what you're gonna vote on, and I can work on that and bring it back. And we can, so you would like me to define, and actually it's kind of funny, it's unresponsive or progresses, so I guess that we should maybe do a little bit of wordsmithing there.
Yeah, you could kind of combine those.
I don't
Yeah,
know
I
what,
think-
and I don't know what pectinosis is, that was just in there, I suppose I could find out. But yes, I can definitely work on that a little more. The chemo denervation also has conservative treatment in it, but that's how it was previous.
Yeah, I think, I mean, it seems like a good comment and worth defining. I mean, I think in clinical experience, you know, people probably don't get good adequate trials of fiber and water and stuff, so, you know, it's specifying what at least some of those components need to be, makes sense.
And since our colorectal surgery colleagues are still delighted about our hemorrhoid changes, maybe I can get them to. I actually reached out to them about this, because I thought they would actually be happy to know, and I never heard back, so I will ping them again.
And Ariel, are we also talking to GI folks or just internists who may see this before, you know, in the chronic stage? I only mentioned that the surgeons may be very biased.
Excellent point. Okay, I will make a note to talk to GI primary care.
I mean, I don't think GI docs themselves are gonna see much of this. It's gonna be primary care and then surgery. But as long as you have a unconflicted colorectal surgeon, i.e., you know, one who's in a system that doesn't get compensated for doing more surgeries than they need to, I think they're gonna see the folks that are referred prematurely. So.
Great, thank you.
Sorry, just taking some notes. Any other comments on anal fissures? Anything else that you want me to work on? We talked about cerumen impaction, which is basically when wax gets in your ear builds up in your ear to the point where you're either having pain or trouble hearing. We currently cover it on first 5 or 6 lines, but we don't use the code combination that CMS states is the required code combination for the, you know, sort of the standard coding. So the initial staff recommendation was to do the code pairing so it's basically cerumen impaction and then like ear lavage. That's only on an uncovered line. We don't have it on any of our covered lines. And then delete it all from all the other lines. The BBBS members felt that we should just leave it on all the covered lines where it is currently, just in case we've trained providers to be using a different diagnosis, even though it's technically incorrect coding. So that change was made. So the staff recommendations 1 to 4 were approved, but not 5.
But also 6.
Oh, yes, yes, and actually there's 2 parts. So this is another one where I'm trying to get rid of lines for you guys to review as part of BUP. So this is we're gonna cross out the below the line effective in January 2025 and then delete that line effective January 2026. Any questions, anything else about that?
So Ariel, can I ask a question? This is Ben.
Yeah.
So, I mean, we have to very frequently remove cerumen when we're assessing an ear because of concern for
Otitis.
Yeah, but it feels like a very different thing because we also deal with foreign bodies, you know, beans and beads and all that sort of stuff.
And I put this on the foreign body and the ear line. So,
But so am I interpreting this correctly that in order to get it paid, you would have to list it as foreign body in
no,
No.
you would list cerumen impaction.
Okay,
So
perfect.
that, so the
Then we're good.
diagnosis got moved there.
I missed. Okay, I apologize for that. Forgive me.
But with
I see it now.
But you can still, because we didn't delete it from the other lines, if somebody billed hearing loss or otitis media or something,
Yeah.
that would still go through the system.
Okay, that's perfect. Thank you. I apologize for being a little bit dense on.
No,
I think that's why we're doing this. So that would be native body.
yes, non-foreign body in the ear. Actually, it's usually Q-tip induced foreign body in the ear.
Q-tips.
Okay, sorry, my little anti-Q-tip bias. The next issue definitely came from the BUP project. Central retinal artery occlusion is actually a form of stroke, and we only have it below the line. We moved it to the stroke line. I spoke with our ophthalmology colleagues. They requested a few ophthalmology codes be added to the stroke line that they use as part of their evaluation for this condition. And then the thrombophilias, these are a range of genetic conditions that cause you to be more likely to have blood clots, such as a DVT or a PE. And they're on a non-covered line. I talked to one of our hematology colleagues who was really adamant that we needed to cover these. In some cases, people don't need treatment, but in many cases, they do need like long-term anticoagulation therapy. So the proposal would be to put them all on a covered line and then get rid of another below the line. So same thing, strike it out and for this coming January and it'll be deleted for 2026.
Yeah. You know, this gets a little tricky. I mean, I'm not arguing against it, but there's controversy over whether you need to test for all this stuff in patients with
Right, but
venous
these aren't the
thromboembolic.
tests. These are, you actually have the diagnosis.
Right, but I guess what I mean is that you're
Oh,
gonna be
cover the
treating,
condition,
you're gonna be treating venous thromboembolic disease regardless. And a lot of times we don't test to uncover one of these conditions.
But if somebody is tested, like they have recurrent pregnancy loss and they have
Right.
this anticoagulant,
Yeah,
then
absolutely.
you would get the hematologist.
Yes.
You might get a consult, you might need. Right now, they're probably being covered because we aren't PAing aspirin and DOACs, but.
Well, and line placement doesn't affect diagnosis.
Yeah.
Right, so diagnosis, you don't need to fund it, it's just if it's medically appropriate, which then we would look at the guidelines that you're talking about.
Yeah.
So really, the placement doesn't affect the diagnosis.
Yeah, and when I was researching this, there is so much debate in the literature about when do you test for this and, yeah.
Yes, we review this at least once a year when I'm on service. Comes up, but, all right.
Any questions about any of these biennial review changes? And thank you very much for giving me like 6 less lines to deal with. Thank you. Okay, we'll go on to Ehlers-Danlos syndrome. We had a very robust discussion about this morning. So Ehlers-Danlos is a genetic condition in which you have a mutation that causes your connective tissue, which would be the fascia, the like linings of the arteries, all the things that kind of make the body stick together are not as strong as they would be in somebody without this condition. And it unfortunately is a huge range from being basically asymptomatic to being incredibly impacted and disabled. There are about 30% of the people who have an Ehlers-Danlos diagnosis can have a genetic mutation that we can test for and verify. The other 70%, we don't know the genetic mutation, there's no test. There are international criteria for the diagnosis that were approved in 2017 or 2019?
2017. Ariel, this is Daphne. That's page 236 of the packet.
Thank you so much,
Thanks.
Daphne. So we had a very robust discussion this morning. The initial staff recommendation had been to either keep it uncovered or move it to a dysfunction line to pair with physical therapy. That went out for public comment. We got 61 public comments, which I think is a record from patients, caregivers, some providers. And they all universally wanted this to be moved to a covered line. Unfortunately, many of the things that they felt that they needed that weren't being appropriately covered were things that HERC doesn't really have a lot of levers. So provider education, better pain management, better coordination of care. These are all wonderful things that I really hope we could have, but we don't have any levers to move that. We have kind of moved it up the chain in the OHA to kind of let people know that we've heard that this is an issue. The evidence review that I did actually finds very little to no evidence that physical therapy in the absence of like an injury or other damage is actually effective. Cognitive behavioral therapy, there's evidence that it's not effective, although many of these people also have comorbid anxiety or other things, and cognitive behavioral therapy could be extremely helpful for those types of things. We had two experts, Dr. Alina Guggenheim and Dr. Sonia Sosa, who came this morning. We had a presentation, and they strongly urged us to cover this. They wanted physical therapy. They felt that maintenance physical therapy could be really helpful. Just of note, we do cover maintenance physical therapy. It's habilitative rather than rehabilitative. And they also noted they were having some trouble getting testing, like echocardiograms and some genetic tests. Although those are supposedly diagnostic, and they were having some trouble getting people referred to other specialists, although it's unclear if it's because of just general access problems to a lot of these subspecialists versus the fact that it's not a covered diagnosis. So in the end, the proposal was, and the staff, after all of the public comment and the additional evidence that the public provided us, had actually changed our recommendation to just, we should move this diagnosis, and we found a similar disorder of connective tissue diagnosis on a covered line. The proposal was to move it there. However, there was a sense that we should write some type of guideline about what we want to have covered or not covered, and also how people could get diagnosed. So there is this international criteria that is available. And one of the suggestions was that we reference that people should have Ehlers-Danlos as diagnosed under those criteria. So staff were directed to talk to medical directors and work with their experts and come up with a possible guideline. Did we vote to move it, or did we table it? We approved.
Approved 4-2.
Yeah, we have that.
Okay. So yeah, it was a 4-2, so not an unanimous decision to move there's 5 or 6 ICD-10 codes for Ehlers-Danlos syndrome to the covered line, and then staff will bring a guideline hopefully in November for you all to consider.
Yeah, I mean, I wonder if we want to discuss a little bit, looking at what the expert was saying there, that in what you were saying, Ariel, that in practice, we're talking about physical therapy largely, right? And they're basically, it doesn't seem to be a coverage issue because PT is being covered just under whatever injury that you would be ordering PT for.
Yeah, I think the experts reflected what staff was kind of saying, that this is sort of a symbolic way to recognize that these people have a condition, possibly create more visibility, and maybe people might want to be educated.
Right, so I mean, that's the part I'm bringing up here. I just want to make sure that we feel that that's what we should be doing with our decision-making. I don't know that I can think of other conditions for which we would have rationalized moving above the line for that kind of reason. Not that that's not useful, but I just don't know that this process is the way to do that. And as even though HERC is changing, I still think that the notion of sticking to evidence and having, we have to be careful about setting precedents and stuff like that. I think that remains important. So if, anyways, I think we should discuss a little bit. That,
Sure,
it
of
seems,
course.
the rationale for doing that seems a little bit out of line with other decision-making we've made in the past. Larry?
Yeah, would it be helpful to talk to some additional experts, rheumatologists, or?
I reached out to rheumatologists and neurologists. Both of those groups felt that this was not in their wheelhouse, that they don't
Really?
treat these patients.
Yeah, my wife is a rheumatologist, and I asked her, and she immediately says physical therapy. So they seem to all refer back to that. Mark?
No, I share the same concerns in that on the UM side, we do receive these requests not infrequently. And at the current state, they're generally approved for physical therapy, or there's some sort of injury or some sort of thing that needs to be done. So I'm not all unconvinced that the current system is not working.
What we heard was that some providers have reported that they are having trouble getting this covered, and it seemed to be a mix of if there's any unfunded diagnosis on the diagnosis list, either the PT may refuse to see them or the plan may deny, and whether that's accurate information or not, there's a perception. And so it gets rather complicated and confusing to tell what's going on.
I agree. This is Daphne, and from the outreach work that I do, what we hear from patients is that it's not getting covered for them.
Yeah, unfortunately, we don't know why though.
This is Ben Hoffman. I think, it's not that dissimilar from Down, like thinking about Down syndrome. And we know that the majority of children with Down syndrome will have hypotonia and therefore will need physical therapy, probably occupational therapy, probably speech therapy. The diagnosis is hypotonia or speech delay or whatever, and not the Down syndrome. It needs to be Down syndrome plus. And I think Ehlers-Danlos is so variable in terms of its expression, that just that diagnosis alone, it makes sense that it's not going to be specific enough to be able to indicate what's necessary. And as a primary care clinician, I think we've all learned, even prior to coming to Oregon, in New Mexico, where there was nothing like the HERC, if you just put Ehlers-Danlos or something like that, you would be denied, and you had to be more specific. So I don't see a problem with not specifically including Ehlers-Danlos unless we wanted to put that and then put a bunch of sub things underneath it in terms of what's common.
That's interesting. So in other words, in order to kind of hear the public and some of the concerns, even though implicitly you're getting covered for whatever injury you're doing the PT for, if you just name those injuries alongside Ehlers-Danlos, then it all amounts to the same thing, but you have the word Ehlers-Danlos in there, and it may accomplish the same thing. That's an interesting thought.
Yeah, the evidence that I looked at, specifically looking at Ehlers-Danlos just as a syndrome, like PT wouldn't be helpful, but like for a dislocated shoulder, chronically dislocated knee.
You have to strengthen things because your connective tissue, your joints are
High fall risk. I mean, these are all the
yeah,
things.
balance, coordination.
Yeah.
Did you have a comment, Lisa?
I had a comment. It's a little different direction, and I totally I agree with how we've kind of been talking about this. Is this in our purview, how we're addressing it? I agree that needs to be vetted a little further, but I was wondering if we're going to pair it with something. I was wondering why not Marfan's or something like that.
Marfan's is on the dysfunction lines. The dysfunction lines have tons of interventions. They're actually kind of a problem child.
Yeah, it is. Because in a sense, I mean, and
that was brought up this morning.
Hurry
it's very similar. There's nothing to treat Marfan's itself, but we treat the complications.
Okay. There's a good reason. I'm just kidding.
Yeah, I mean, Marfan's currently, so the dysfunction lines have things like feeding tubes and respirators and bladder treatments and as well as PT and OT. And they're, I've been here for a long time and it's been on like the to-do list for like reviewing those for like ever.
Some of the Ehlers-Danlos can have like digestive problems where that is missed a lot and you know.
I'm wondering if it would be helpful also to talk to any physiatrists, if they might have a different, or some additional information to offer.
You know, that's an interesting thought. I mean, I think that I know that Ariel and the staff had done a pretty wide search for, you know, experts that feel that this is within their purview, and it's even difficult to find that. Yeah, I still remain concerned that we're kind of blurring the lines on what, you know, what we're good at doing and what the public is hoping for, which I understand and empathize with, but it is maybe better accomplished through other means. And I think we're all feeling a little discomfort with the marked variation in, you know, understanding of EDS, and, you know, whenever it's a little squishy, I think we do have to be concerned about precedent setting.
So there's some
here
functional drawback as well. So I share those concerns. I was one of the nays. When you put something above the line, you can also, I've had them linked and used with the comorbid rule, in that, like for POTS, we intended just PT and OT, but when you see it's now a funded diagnosis, you can use the comorbid rule and say, hey, this thing that's typically not studied or not linked can be, and that needs credence to it as well. So even, I think we have to put, if we do decide to bring it above, you have to put kind of a significant amount of guardrails on it to kind of define what our true intention was. And from what we heard this morning, we couldn't nail down a functional thing that we're missing. In terms of, does it pair above the line or below the line? There's definitely difficulties with access to care, but that's kind of not above the line, below the line thing.
Yeah, that seems like, from what Daphne was saying, which is valuable. You know, for example, I wonder if some of that could be addressed by, you know, educating CCOs or providers that see these patients to, you know, code for the injury, you know, that kind of thing, where it seems to be working for some providers and maybe not others. Chris, did you have a question?
I'm sorry, I missed the meeting this morning. It sounded like a very lively discussion. I'm just trying to frame, it sounds like, I mean, I guess what I found notable today is how much feedback we got from the public. And I wonder if all of that is that they're not getting access to any of the care, is it putting it up on the covered line, giving it credibility as a disorder, as a disease, as a syndrome? And is the guardrails, because it seemed appropriate that it was going to be under the connective tissue. Is the risk there that it's opening up for everything that's under the connective tissue, just like what is there for lupus? Or is it that there's questions about how it might be applied?
Yeah.
Is it a risk for overuse?
I mean, I don't know if you're referring to my concerns, Chris, or others, but I just think that the notion of trying to use this process to legitimize whether or not a diagnosis is real, it doesn't seem like the right process to do that. It's a really complicated question that's very slippery, and a useful one. I mean, I'm not saying that it shouldn't be pursued. I just don't know that HERC is the right forum in which to pursue that. And I worry specifically about doing something for that reason.
I can probably answer that.
Yeah, I'm looking-
Anything more specifically? So yes, it could be overutilization. What we're talking about is moving it to a line that wouldn't pair with PTOT, so it wouldn't change that. And then
Oh.
it makes, right, and then it makes the sort of DME medical question, that would go to a CCO to determine medical necessity. And through the review and through the couple of meds they discussed and some of those interventions, they aren't. So then you kind of get a little piecemeal. Each CCO would have to look at those individual cases. And so it really wouldn't be as universal or as consistent. So yes, and there can be some overutilization. So that's, we were kind of really trying to nail down, does above or below the line really change access? And it shouldn't. If they have those certain comorbidities, those should be funded and paired. Yeah, or if it's diagnostic, those things don't need above the line diagnoses. So where the diagnosis falls shouldn't. It doesn't mean those processes are perfect and always work as intended or written, but the theory behind it, which is what we have on that, those sort of guidelines, it shouldn't change that. Does that answer the question a little more directly?
I think so. It's I don't know that there's a direct answer.
Yeah, there's a lot of parts to it. So yeah, yes, yes.
I think we're all wrestling with it, you know, our discussion is reflecting some of the complexity here. Larry?
Yeah, I think whoever was speaking just framed it very well. It sounds like three parts. It sounds like patients want recognition of this syndrome. Then there's an aspect of clinician education. And then there is the aspect of, well, if someone actually has a symptom, it can nonetheless be treated without naming it necessarily. And I think, and I agree with Devin, that this is not the forum to get into whether or not a condition, I guess I forget how you framed it, Devin, exactly. But I think we need to focus on, is there a problem and should it be covered? I think that there is a problem and it should be covered, whether you call it EDS or not.
Yeah, thanks. Okay, yeah. Yeah, I think we're talking about kind of legitimizing what a condition, which which again, I mean, I think the implications of that are, so everything else we don't cover. Yeah, I mean, it's not like we're saying all those things are illegitimate. We just don't, that's not how we approach things.
Right.
So it's just not the right framing for what HERC does, in my opinion. Other thoughts? So I guess we need, what do we need to do to move forward with this?
Leslie has her hand up.
Oh, okay, sorry, I didn't see you, Leslie.
Hey, that's okay. So I think I'm thinking along the same lines as others, but I specifically would like to focus on what isn't being covered and which type of provider is seeing these patients, because I feel like it's almost a provider education issue, potentially, thinking back to what Ben was talking about. When there is a chronic condition, oftentimes the thing that is referring, there's the chronic condition, and then there's the issue that's referring someone to physical therapy or further therapy is often not the overarching condition. It's, the other piece, it's a sprained ankle, it's whatever it is. And that's been actually one of the things that has been difficult from the disability advocacy lens. It's been really hard to quantify health disparities for people with disabilities, primarily because when you start to pull claim coding for, different types of therapies or different things like that, oftentimes, the overarching chronic condition isn't included in that. And so you'll just see a PT visit for a sprained ankle, not necessarily the background of the chronic condition that may have contributed to the sprained ankle. So I think this is just a long way of saying, I'd like to know a little bit more specifically about where the access point is happening, what type of providers are involved. And I agree that it's setting some different precedent if we start to set you know, kind of this overarching chronic condition as the entry point to a type of service that typically wouldn't be associated with a chronic condition, like physical therapy, for example, is usually, you know, there specifically for an injury or other type of thing rather than a chronic condition. But again, I'm your non-medical HERC member, so if I'm misspeaking, my apologies, but that's the kind of information I'd like to know, is specifically what is the access problem.
Yeah,
I
no,
think that is an excellent point to be able to address health inequities. Is there a disability that's associated with the condition? I think that's a really good point.
So is it, just from this summary you have here, is PT basically the point that
So we were told
Leslie is
this
referring to then?
morning by our two experts that they weren't having trouble accessing physical therapy, but that they were coding the sprained ankle, like Leslie had mentioned, they weren't coding EDS.
But in terms of the treatment that the kind of the choke point that we're talking about, it would be things like PT and cognitive behavioral therapy, is that?
They didn't indicate that there was any problems accessing cognitive behavioral therapy if you use something like anxiety, accessing PT, accessing medications. They thought that they might have a little bit of trouble with echoes. This is a condition where you, like Marfan syndrome, where you would want to do an echo. But that is a diagnostic service. The genetic testing for looking at the subtypes, that also is a diagnostic service. And there are a limited number of providers that are seeing these patients, but I think that's because of provider education and access, not anything that we're doing.
Yeah, I mean, the sense I get from the rheumatology community, at least, is that they feel that they don't have anything to offer, but that's not something that HERC would, you know, be able to intervene on. Leslie, does that kind of get at what you're talking about? Just naming the specific treatments that they might or might not be
Yeah,
having trouble getting at?
yeah, I think so. I mean, I think it would really help understand, like you said, those choke points would be really great.
Okay, yeah, so it sounds like those theoretically would be PT, you know, cognitive behavioral therapy, but they're saying that you can often get those anyways. Mark, did you have
I do. On the question of echocardiography, for asymptomatic patients with Ehlers-Danlos, a quick literature review says it's not recommended.
Right.
So I would say that, so just clarification on the echo, that not recommended asymptomatic. If you're symptomatic, of course. But
Right, so the point that was brought up by one of our experts was that the 2017 guidelines, one of the criteria for diagnosing EDS is are structural heart issues that you need an echo for diagnosis. So
You can diagnose without it, but if they don't meet those other criteria, that could be a criteria that then they could meet the diagnosis.
Right,
Because
you can't check all the 17 criteria without.
Right, you don't need all 17
You can't rule it
necessarily, because it's like, you know, 1 major, 3 minor, you know, that kind of thing.
Right,
So
but you
some
can't
of
rule
that-
it out unless you check, right? Is that?
Yeah.
Yeah, technically,
But then-
I think it is recommended for a couple of the subtypes, it's not for vascular and classic.
but well, for so like there are vascular subtypes that
Yeah.
have genetic markers and they definitely
Yeah,
need,
it's
like, I think
recommended
once
for
a
screening.
year
Yeah,
echo,
So
something
there are
like
heard
that.
some
about-
subtypes.
We heard about difficulties getting those genetic tests. We heard about
Well, they had
bad
tried.
outcomes from our cardiologists for patients who didn't get the echoes, so it's.
We heard they hadn't tried for the genetic, right, and they didn't.
Right,
And then the genetic counselors don't see those patients, but genetic counselors are
there's just
incredibly hard to get into.
so
It's a
many systemic
scarce
issues
resource.
that are
Right.
interacting.
The
Yes.
ultrasound one was a little, I guess we didn't get into.
And
what
Dave
type of
Sanger, who was here this morning, said he's having trouble getting echoes for some other cardiac, like, he's a cardiologist
Yeah.
and he's ordered, like,
Yeah.
that's what they do, right? They order echoes and he said he's had some.
Lots of things.
I know.
That is one thing that you commonly
Very
get.
commonly ordered tests in cardiology, and he said that he was having trouble getting echoes approved for various
Oh, I guess.
So,
That may be another issue. I don't know. Do you have a?
So I really liked the, or I think Dr. Hoffman, when you mentioned like Down syndrome, like how, just from like a consistency perspective, how is like Down syndrome, do we know off like the top of our head?
it's on the dysfunction lines.
Wow.
So as I'm sitting here listening to this conversation, what's percolating into my head. So we are doing this benefit updates project. We are going to have to look at all of the many conditions that are similar to EDS that are below the line. And then there's a whole bunch in the dysfunction lines we haven't looked at because I'm scared of the dysfunction lines. But it seems like as part of the BUP, what might be something you all would be interested in doing is creating an evaluation only line. So conditions like Down syndrome, Marfan's, EDS, they could get an evaluation, office visit, but then they would need other things to get other stuff.
I'm confused now. So because diagnostic stuff, we're not talking about, right?
Right, so with the new world with BUP, we are not gonna be able to say that certain diagnoses are just not covered anymore. So,
Right, but with the diagnosis, you don't need a funded condition. You
right,
just need medical necessity.
There are some raised hands here. Can we address those, please?
Yeah, sorry, we were just following that earlier thread. We see you both. Go ahead, Larry.
I'm just wondering, I put it in the chat. Is there a way to attach a chronic condition diagnosis and a state of disability diagnosis to a particular symptom? Like connecting connective tissue disease, a state of disability, and a sprained ankle, kind of like a Medicare diagnostic related group. Would there be a way of doing that which would both reflect the actual pain or problem that someone has for which they may need physical therapy, the fact that they have a connective tissue disease, and it would also reflect disability, which gets us to being able to capture not just the sprained ankle or whatever, but also the disability, which then we would be able to better get an idea of, are we addressing problems in terms of people with disabilities better?
Yeah, and I think that this had come up before. Let's hear from Ben, and then we'll circle back here.
Yeah, I just want to go back to what we were talking about before Larry spoke, and I don't disagree with that. There is no intervention for Ehlers-Danlos syndrome, right? There are interventions or things that need to happen based on manifestations of Ehlers-Danlos, and so I mean I've taken care of these kids. Their care is in the medical home and physical therapy, and they need to see a geneticist because of the heritability and understanding that. But the rest of it is all, if they sprain an ankle, it's because they sprained an ankle, and the Ehlers-Danlos may have made it easier for that to happen. It may make the ankle sprain more severe. It may make it more recurrent. But if I'm sending them to physical therapy, it's because they had an ankle sprain. And I can say, it's complicated by Ehlers-Danlos, but the diagnosis of Ehlers-Danlos is immaterial.
Yeah, and we can think of a zillion corollary examples. People are at heightened risk for sprained ankles for many different reasons, but you still just code the sprained ankle.
Exactly. Yeah, that was my point. Yes.
Yes.
PT is useful for sprained ankle, but PT not useful for EDS type of thing.
right.
So, okay, so I think we're maybe, I don't know if this is a consensus-ish sort of thing where
You want to reverse, I'm hearing reversing of BBS, is that just?
I think we're
The
generally
Medicaid
feeling
medical
uncomfortable
director has
with
her
it.
hand up. Can we recognize Dawn Mautner, please?
Oh, yeah, we're not seeing, I
Can't
can't
see
see,
She's
we
a
can't
guest.
see everybody,
Yeah,
sorry.
Dawn Mautner's a guest. She's not.
Dawn, go ahead.
She's.
Sorry, hi, everybody. Can you hear me?
Yeah,
Yes.
Sorry, we didn't see your hand. We just only see some people on the screen.
Sorry. I wanted, good afternoon, Dawn Mountainer, she, her, and Aya are my pronouns. I think I know most of the people in the room, but I'm not sure who all is on the call. Oregon's Medicaid Medical Director, thank you for the acknowledgement here. And thank you for taking the time to try to suss out how to make sure that these individuals are able to access the care they need at the same time as not setting ourselves up for inappropriate utilization by naming a condition that does not, to Ben's point, have in itself a treatment or perhaps more focally a cure. That said, I want to acknowledge the predisposition of the individuals with Ehlers-Danlos to any of a variety of complications for which evaluation and treatment are needed. And if what we are hearing from the community is that they are having difficulty accessing the services that they need to access because our coding restrictions are returning their requests for services, then it seems clear that somewhere in here we need to figure out how to make it easier for them to get what they need to get for their patients, and acknowledging the underlying genetic driver of the vulnerability or the predisposition in this case, the connective tissue disorder, seems to provide kind of the background that a receiving clinician might need in order to do an appropriate job of delivering the service.
Yeah, and I think our question here that at least I've been hearing, Dawn, is whether the problem we've been hearing from the community, I think we all recognize that this community is having problems. I'm hearing from commissioners that they're not sure it's because of the code. It's probably from a lot of other bigger systemic issues.
So, I mean, we've talked about this kind of clinician education piece, several times now. People have brought it up. And again, it's not necessarily what HERC does, but since it's come up a number of times, is there a mechanism to kind of, I don't know, send something out to CCO directors and kind of, say that, FYI, some people are having trouble with this.
I can bring that up. We have a monthly meeting with the CCO medical directors. I've definitely brought it up before, but I can bring it up again.
So, yeah, I mean, I think then, we can still take the concern seriously, but address it, in the direct way. So if they are having problems, figure out where those problems are occurring. From what I'm understanding from our kind of arriving at consensus process, is that it's not clear to us that the problem lies with the coding and our determination here. So if that's true, it sounds like we're kind of voting, or we're moving in the direction of maybe rethinking the decision this morning. And so do we have to do anything right now, or do we have to vote on this one specifically and then come back to the rest of it, or?
If I may, one more.
Yeah, of course.
Please. Thank you. Thank you for coming back around and noting those. One of the ways that it was discussed this morning was around Marfans. So, Ben, to your point, is there a way to treat Marfans, and is it on a covered line?
No. I mean, you can't treat the underlying disorder. You treat the symptoms, and you monitor for things that could be complications. Like
Ehlers-Danlos.
Yeah, right. Right, the same thing as Down syndrome, and it just provides context.
Right. What line is Marfan's on? It's covered, right? It's on a covered line, right?
It's on the dysfunction lines.
Is that where this belongs?
Just to be clear, Marfan is on the dysfunction lines, which would pair with durable medical equipment, medication for the symptoms, physical therapy, chiropractic.
Also pairs with feeding tubes
Right.
and
Lots and lots of stuff.
ostomies, tracheostomy, and
Respirator.
yeah.
I-
So there
I-
may be, there's been a need to go and look at those dysfunction lines.
I think there's an additional importance to identifying a condition along with the symptom that can be a condition that may not be treatable, but or curable rather, but results in a condition for which someone does get covered care, and that is the data capture. And because the diagnosis codes allow us to capture and categorize data that tell us about how are we doing overall in terms of care, and also for the future in terms of being able to see, and will there be some additional cure or treatment in the future. And again, it goes back to the one of the purposes, one of the goals is reduce and eliminate health inequities, and the diagnosis code plays a role in that for data, in terms of data capture. So I don't want to lose sight of that.
Thank you, Larry. I'd like to address that.
Yeah, go ahead.
So yes, what you're hearing is we have whole people with lots of conditions and they relate to one another. Our fee-for-service based medical system has trouble with that, and we're seeing that in this space. And so we're trying to find the best way, the best approximation of what we can do using the tools that we have. And that's, you know, ideally we could create something that would capture exactly the right information. But in the real world, we have providers choosing their diagnoses based on what they think will get paid. We have claims processing systems looking at things in particular ways. We have reviewers using their clinical judgment, which may vary from person to person. So that is the space that we're in here. And thank you for acknowledging that. And unfortunately, we can't create like a diagnosis related group. We don't have that power, so we need to do the best we can to make a policy that serves our members.
Okay, Lisa, and then we gotta be careful on time. We're running out of time here on this. Go ahead.
Yeah, what I'm thinking is we say no to the line change up to lupus, but investigate maybe Ehlers-Danlos as a dysfunction line, and however that works with the BPU moving forward, but not necessarily putting Ehlers-Danlos and Marfan's together, because they do have different needs, maybe in severity and that.
I'm thinking like Marfan's is probably a very accepted diagnosis code for an echo.
Right, exactly, because you have screening, but with some individuals with the support, genetic marker support that you need to watch the arteries. I'm wondering if that exercise to do a study on would that be an avenue that could maybe help access? I'm assuming a few things here, because I'm not that familiar with the disability lines or the functional lines.
The disability line.
Disability, I'm sorry, I'm just,
Yeah.
I'm still wrapping my head around this, but I think they're probably there to improve access and get evidence-based care to people versus just a regular kind of line.
They were created years ago.
Okay.
And I think a lot of what they were getting at was things like what Ben Hoffman brought up, like Down's kids. There's nothing we can do
They
about the
need more
Down syndrome,
supports.
but they might need feeding tubes. They might
Yeah.
need incontinence supplies, they
Right.
might need.
Yeah.
So,
It's easier access in a sense.
yeah,
Right, but some of that doesn't apply to this group.
Yeah, EDS would have its own, I mean,
It's more
it commissions its own.
Right, Marfan's is a specific etiology.
Right.
and we
To
have
be
genetic
clear, there
tests.
are hundreds of conditions on those dysfunction lines.
Okay.
It's a
Mess.
lump. It's a lump of things and medical necessity applies, obviously.
Yeah.
Which in the review we saw is
You
not
do
applicable
manage,
to
right?
the treatments that we discussed, right?
Okay, so just in the
Yeah.
effort of moving us forward here, I think we're starting to arrive again at similar things with some messiness. Some attraction in moving it to the dysfunction line, but the problem with that is it sounds like the dysfunction line itself is kind of a mess. And it's gonna be re-reviewed, so it doesn't make sense it doesn't say, it makes sense to me to add to the mess of it. There's a need to explore if there are real choke points and access to things like PT and CBT that I think we're all agreeing could be useful for specific complications associated with Ehlers-Danlos, and maybe reaching out to the CCO folks to find out more about that is one way of doing that. And I think otherwise, I think we're wanting to, reverse the decision from this morning. So do we?
If you wanna vote on that separately, and then we can
Vote on that separately, okay.
Next step.
the BBS report.
And is this the last thing?
Yes.
Okay, so why don't we do that? So first vote will be on the Ehlers-Danlos syndrome discussion. And this would be a vote to reverse the VBBS decision from this morning.
And could you clarify the VBBS decision from this morning very briefly?
It was to move the 5 diagnoses, the 5 ICD-10 codes for Ehlers-Danlos from an uncovered line to a covered medical only.
I'm sorry, point of order, who made that motion?
Oh, I'm just summarizing. I guess I made the motion. I don't know if I'm
Okay,
supposed to make
you
the motion.
can't make the motion.
I
Someone
shouldn't
else has to make
I
it.
shouldn't make the motion, so somebody else.
Yeah, someone else has to make that motion.
So
Motion
Max
would be-
Kaiser motion.
Yeah.
Is there a second? Second. Lisa Kuza seconds.
All
Can
right,
you just
so
restate that? I'm not clear what we're voting on, and
So,
I just
so
need
this
a quick-
morning, the VBS voted to move the ICD-10 codes for Ehlers-Danlos to a covered line. The motion is to not do that, to basically make no change, keep them on the uncovered line.
yes, so if you vote yes right now, it would be a vote to keep Ehlers-Danlos on the uncovered line. So
May I-
just vote.
Is there another option to table, like we sometimes do, to go back to understand the problem? And
That would be the
fix
second
that?
motion.
I think we might address that next.
That would be, yeah, so you would have
Okay.
to vote this one down to bring up another motion.
Okay,
To Robert's rules.
Because the motion's on the floor.
Fair enough.
put it down.
Well, now I'm
You
confused.
can bring up additional.
So if this motion passes, then there could be another motion
Yep.
to bring the topic back at a future date.
Okay.
Yeah.
All right, so many motions. Okay, so this motion is to leave it uncovered, and then we'll come back to whether we want to come back to this topic at a future date. Okay, so for the first motion that Max made, go ahead and vote in the chat for all of you online. And then we'll take a oral vote here. Aye. Adrian. Okay, and then I'll say aye as well.
Hold on. Just to be clear, the yes is to keep it uncovered.
Yes.
Yeah.
Yes is to keep it uncovered.
Okay.
So the motion's passed.
Okay,
The motion carries with 3, wait, how many votes in favor? We have
5 yes.
5 yes and 3 nay. We need 6 yes for a motion to carry.
Mark voted yes. Chris abstained.
This is
Ben,
Leslie.
no. Larry, no.
This is Leslie. I'm voting no. I'm just having an issue with my chat. I'm sorry.
I think you can vote to table it without reversing the VBS recommendation because there's no,
If we can vote to table without without reversing it, I would be comfortable
Yeah.
with that.
To be clear, if there is no successful vote today, nothing will change. There will be a status quo. If the group agrees this should come back, we could memorialize that with a vote. It looks like the motion to reject the VBS proposal did fail, but we still have, there's nothing on the table that would change the prioritized list anyway.
I make a motion to table.
I second the motion to table till we have more information.
Should we clarify what we're clarifying?
Yeah, I'm sorry, I feel like this is turning very messy.
Normally what happens when you feel you can't make a decision is you send staff back with specific instructions.
I'm wondering what those are.
Yeah, I'm wondering what my specific.
Is it just that we need more time to discuss this and we just have to do this at another meeting?
This is Chris. My understanding is that we don't know where the source. I think we need to address the public comment and their lack of access to care and understand that problem better. And that might, either that's on us or on someone that we need to work with within the powers that be or the decision makers to understand, are those claims getting denied because the physical therapists don't understand, because the providers don't understand, because it doesn't sound like it's a coding issue, right? Is what I'm hearing. But there's a whole bunch of people who can't get these things covered. And I don't want to make it worse for them by, I don't want to mess with I don't think it's appropriate to add it to the coding list because I've heard the concerns, but I also don't think it's appropriate not to do further research before we say that we're not. I just feel like they need to have, there's more information here that we need before we understand whether this would be an appropriate solution or not. Because I don't know what the source of the problem is.
I agree with Chris. And specifically to gather the kind of information that I think Chris has indicated is wanting, I do too, would not only to review the public comments more, but as previously said, to go to the CCOs and actually look at what do the claims data show?
Why are they getting denied?
Yeah, I will let Jason and others speak to, I don't know if they'll be able to, do a whole review of claims data or anything, but fair enough. So basically we need more time, and in the interim, it seems like the specific instructions from the group are to figure out, if and how often people really are running into coverage problems for things that we would otherwise think should be covered. So basically PT for these specific injuries and that kind of thing. And to figure out if that's something that is likely to be ameliorable through a coverage decision-making process or through some other mechanism.
And that's correct. From the CCO standpoint, coverage for PT is limited to 30 visits per year. So there could be many other issues at work that have nothing to relate to the coding process. That's why my thought would be to continue with our vote, and it can always come back.
Yeah, it sounds like we're kind of a little bit at a split decision, partially I think because it's a difficult topic and we haven't had that much time to wrestle with it, and so I think it's okay for us to come back.
Well, I was just going to propose that it seems to me that there are cross-cutting and systemic issues, and we can do more research and try to come up with a clearer presentation about what we do and don't know, what we do and don't control, and the evidence can sit within that framework a little bit, and that might lead to a better decision. We might also get some additional information from Dr. Guggenheim, from the patient members, from other providers in the interim, and we can bring that all back from CCOs for that matter, from the data, as Larry said.
And we'll have had a chance to review the public comments in more detail.
There wasn't a lot of detail in the public comments. It was, we're not getting what we need.
Okay, so I guess basically we need to figure out what we're not getting, what we need means, and whether we can make it better or not.
Right.
And,
There you go.
okay.
And one of the
language.
things that occurred to me when reading those comments was this concept of chair side denials, that a Medicaid doctor knows it's not covered. And so when somebody says, I think I have EDS, they would say to the patient, oh, that's not covered. And so they don't get treatment.
That's a provider education issue though.
So again,
It is.
that's
Yeah,
one of the
it's not
systemic
in our
issues.
purview.
But we can't really address those today. We're running
Right.
low on time. But
Yeah. Okay, so we're gonna now, I mean, do we even have to
That
vote to
sounded-
table it if we're just gonna come back to it?
I'm thinking I hear a consensus that we need to bring this back.
Yeah, we'll bring it back.
Does anybody object to the general parameters giving us?
If we
flexibility?
table it, the codes will stay where they are until this body moves them.
Right, since it has to get approved by HERC anyway, so, basically just in a holding pattern, and we'll come back with more information and a little bit more time to wrestle with this. Okay, good discussion, tough topic.
All right, and then we still need to vote on the rest.
So we gotta
of
do the rest. Okay.
Yeah, is there anything that we changed?
Yes, we tabled the annual.
We tabled Ainer
Fisher's
Fisher's.
DBS report as modified. Okay. Anybody has a motion?
All right, does somebody want to move to approve the rest of it, everything but the Ehlers-Danlos stuff?
Motion to approve.
Second.
Okay. All right, please vote in the chat.
Aye.
And
Aye.
I am aye as well.
This is Leslie. I approve.
All right. Well, that one was easy. All right, so we're.
Oh,
10
sorry, I
minutes
was muted. I was saying motion passes.
Oh, thank you. All right, we're 10 minutes behind and we're gonna end at 4:30. You wanna just power through, or people need a few minute break?
No, let's go.
Let's go, all right. I'm with you, Larry. Let's plow on ahead. That's okay. So Reproductive Health Equity Act report.
This one will be short. This report was provided in your packet. This is a report we're required to complete every 2 years. Basically.
Is there a page?
Sorry, can somebody help me with the page number?
282? Maybe 283?
284?
283.
283, thank you. And this report basically says, don't make any change, nothing needed. The U.S. Preventative Services Task Force is appropriately covering preventive services as well as the other services specified in statute. Since this law requiring this report passed, there has been another law that passed that reinforced the requirement to cover these services under commercial insurance, which is one of the reasons behind this statute. So we do need a vote on this. It is an official report, but it doesn't really have, it will go to the legislature, but it doesn't really have any impact. Are there any questions about this?
All right, so this one seems fairly straightforward. We have to vote?
Mhm.
Okay, so anybody want to move to approve this? Max, you want to go for
Motion
3
approved.
motions? All right,
Second.
all right. Please vote online and in the room here.
Aye.
Aye. Okay.
This is Leslie. I vote aye.
All right.
Motion passes.
Great. All right. Okay, another easy one. Decision making when evidence is limited.
We haven't talked about any of those today. So I know we're short on time. We'll actually go out of order here and have Marcus present first. His presentation will be contextual. And then I want to get into the slide Liz has up now, but if we could go back to Marcus's presentation. Thank you.
Oh, okay, so,
288.
288.
very good, thank you.
All right, good afternoon, everyone. My name is Marcus Bachhuber, and I'm with the Center for Evidence-Based Policy. Just to remind folks that we are contracted by HERC to help with evidence reviews, and I'm presenting this on behalf of our team. So, that's okay, Jason. Thank you.
Well, they can't even see you.
No, I have it on my computer.
Yeah, but they
Oh,
won't
they
see
can't
you.
see me. Yeah.
They still can't.
Still.
Yeah.
Yeah.
Okay.
Yeah.
There we go.
There. So just as an overview, as we all know, coverage decisions need to be fair and equitable, and that requires that they're relevant, transparent, possible to revise, and systematically documented. So we need to have a systematic and transparent approach based on the best available evidence, which will help us make the best decisions possible. Next slide, please. So this is a review of the HERC's charge. This will be familiar to everyone here. The first bullet is about developing the prioritized list. The second is about identifying and disseminating evidence-based guidelines, and the third is comparative effectiveness research. So as you all heard today and in previous meetings, the prioritized list is going away, but really this refers to the core function of the HERC to critically evaluate health services and be able to compare the effectiveness of different health services. And that's really what I'm talking about today. Next slide, please. So when we talk about comparative effectiveness research, we just mean research looking at different health services, identifying is it effective, is it safe, for whom compared to what, and for which outcomes. And these are reflected in the scope documents that get sent to the center. These are decided by the commission. And then we produce the coverage guidance that we've presented a number of times. For each outcome, the coverage guidance contains this rating here that you're familiar with at the bottom, which assesses the magnitude and direction of the effect that we find and the confidence that the effect is true, rating the confidence from very low to high. And this is what we call the grade assessment. You can go to the next slide. And grade is a group of folks that do this methodology, and grade stands for grading of recommendations, assessment, development, and evaluation. So this grade assessment of the evidence in the coverage guidance gets sent back to you all, back to HERC staff. And of course, you can't make decisions with evidence in a vacuum. There's a lot of other factors to discuss, to consider, especially in a program as complex as Medicaid. So some of the factors that are also considered in the coverage guidance document and in the discussion are the balance of benefits and harms, values and preferences, resource allocation, and then some other considerations like guideline recommendations, expert opinions, and other payer coverage standards. So I'm going to talk a little bit now about it's a same group grade, but it's a different product called the Evidence to Decisions Framework. And they produce this as a way to translate evidence into decisions, like what the work of the commission is. So there's a set of 12 criteria, and I'm going to go through them pretty quickly at first, and then we'll take a little deeper dive into them in a bit. But these 12 questions, they're not meant to tell you what to do or guide you into a specific decision. It's to make sure that you consider in your discussion all of the relevant points, all the relevant aspects of the decision so that you arrive at the best decision possible. So the first one is really kind of an overarching criterion. It's about, is the problem a priority? Is it important? And then the remainder of the first 6 are focusing on the benefits and harms, the balance of the benefits and harms, and the certainty about the benefits and harms. You go to the next slide. The first 7 through 9 are about cost and cost effectiveness. 10 is about equity, and 11 is about acceptability and feasibility. So we can take these criteria and do a little bit deeper dive against what HERC does, or what's in our coverage document, our coverage guidance document that we produce, and try to identify some overlaps and some potential gaps. So for the first criteria in the grade evidence to decision framework, is the problem a priority? So it's not explicitly in our coverage guidance, but it's prioritized, the topics bubble up through a transparent public process. So I think it's safe to say that that the problems that are prioritized are deemed important by the commission. When we talk about 2 and 3, these are the benefits and the harms. So that's really one of the core aspects of the evidence review that we do at the center and provide in the coverage guidance. So the type of outcome, those are provided by you all, and then the effect and certainty of effects we evaluate. And along with harms, we provide extra information on frequency, type, and seriousness of harms, as well as duration and timing. And then number 4 is that certainty of evidence, which we produce from the scale from very low to high. Next slide. So the 5th is really about values and preferences. So how do people value different interventions and what goes along with them? So those are taken into account in the document under the values and preferences section. We don't formally, at the center, we don't formally review research on this topic, but the draft decision, the coverage decision is published for public comment and public testimony is considered. So in that sense, the values and preferences information on values and preferences can be gathered in that way. For number 6, does the balance between desirable effects and undesirable effects favor the option for the comparison? So we explicitly in our coverage guidance consider the balance of benefits and harms in the assessments for each outcome. That's actually a section as well. Number 7 and 8, when we talk about costs and resource use, these are pretty difficult topics as we've come to see. A lot of the information that we're finding in our evidence review uses it's either based outside the US, so it's not really applicable to the US at all, or even within the US, it doesn't use the reimbursement methodologies that OHP would use. So there's not a generalizability there. And the actuarial data that would inform how much it will actually cost to the state, that's not available when we do our review. That's available after the HERC's decision. And in addition to number 9, we around cost effectiveness, if there's a cost effectiveness outcome that's identified, that's made an outcome, we would do a formal assessment on that. There hasn't been since I've been here. We don't do at the center, we don't do any of our own economic modeling. That's not what we do. And also our state law prohibits us from considering qualities or quality derived measures. So that results in kind of a mismatch between the bulk of what's out there in the research evidence and what we can include in the coverage guidance document for you all to consider. For 10, when we talk about equity, there's definitely some consideration of special or subpopulations in some discussion, but no formal equity criteria that are employed by OHA or HERC. And then 11 and 12, acceptability and feasibility aren't necessarily formally considered in our coverage guidance document, but the draft decision is published for public comments. We gather information on feasibility and acceptability in that way.
I have a Freakonomics question.
Sure.
In terms of in terms of 9, I think, in terms of number 9, is any consideration made in terms of treating a patient so that, for instance, they can get back to work? And is the back to work portion any type of consideration in this analysis?
Well, I mean, so I think, Larry, when we're talking about the benefits and harms part, when these coverage guidances are, when we go through the topic development process that we also vote on, the outcomes are voted on ahead of time. And so, employment, return to work, these are all things that can be outcomes of interest for any given topic. Depending on what the topic is. So I think it would be captured, some in that respect.
Okay. All right, thank you.
Go to the next slide. So just to summarize here, there's a lot of areas of overlap between this framework and what we do now, but there may be some gaps where you could be a little bit more explicit in the decision-making around specifically patient values and preferences, economic assessment and value, equity, acceptability, and feasibility. So in my time, my fairly brief time here, a lot of decisions are based on discussions that all incorporate these things, but they're not captured as formally or systematically as they potentially could be in those discussions. Next slide, please. So I just have a couple of discussion questions here, which you all can think about and turn it back over to Jason. If we want to discuss these now or after your presentation, either way to do it. But are there any important elements that should be added to the decision framework used by the HERC or to formal deliberations or anything else that you all want to put on the table for discussion?
I wonder if, just in the interest of time, I don't know what you're gonna say. Does it make sense to present more and then have a bigger discussion?
Yeah, why don't we present those slides, because I think I can do that relatively quickly. We're probably not gonna finish this today.
No, but
let's get it all in.
But I think we'll have more information that might be relevant to some of this, and then if it's okay with everybody, then we can engage in a discussion. Does that sound good? Chris, is that okay?
Yeah.
Okay, great. All right.
So we discussed this with leadership a couple of weeks ago, your chairs and vice chairs, and they asked for, we don't have it outside the coverage guidance process, which is pretty well defined and still imperfect. We don't have as much of a formal methodology for the VPBS decisions like ALOS, ANLOS, which we just reviewed, and many others. So they asked for something that we could put up on the projector or some kind of aid to help us make sure we are making consistent decisions and considering all the factors. We're not getting blown about by testimony or, not losing track of the big picture as we're focusing in on an issue. And so I developed this attempting to bring in some of the factors that I've heard discussed here that I see expressed in the evidence to decision framework that Marcus presented as kind of a cheat sheet. And there's 2 slides to it, so don't be alarmed if some important things are missing from this first one, because they are, and that's by design. So I just want to review this and get some feedback, both on what Marcus presented, this approach of having something like this, and on the specific content. Obviously, we'll need to bring it back for more work. A background to this is we did create many years ago, some of you have heard us talk about this, a flow chart to attempt to make a flow chart path that could be followed. These decisions are too complex for that. They're multifactorial. They're not yes or no. There are shades of gray in multiple dimensions. But there are some common pathways, some common principles that can help us focus in on what the key issues really are. I think we just ran into some of that on that last topic. So that's a great backdrop for this discussion, although every topic is different. So let's just give this overview. Let's get some reaction in the time that we have left, and we will bring it back based on that. So this is the first slide, and you'll see along the left side, we said we're centering everything in equity. That's the orange bar. That means that applies all the way down. We need to be conscious of our biases, conscious and unconscious. We need to be thinking of questions we should be asking relate to how this affects certain populations that experience inequities. That's not just a one-time thing we can plug in and check the box we can check off. It needs to be embedded in our work. That said, there are some boxes we need to check off. And one of those, the first one on the left there, is the evidence source. Where is our information coming from? Is it a systematic review? And how good is the underlying evidence base for that systematic review? A systematic review of 42 large randomized controlled trials conducted with good methodology is different than a systematic review of 42 observational studies with 12 patients each. If you don't have a systematic review, then you're looking at randomized trials and trying to paint a picture with those. If you don't have randomized trials, you're looking at observational studies. And then below that, expert opinion. And again, this is a simplified version of what some of you may know as the evidence pyramid. Just put there as a reminder. The second column there is bias. So what bias may be embedded in any of those evidence sources? Is there confounding in randomization or masking or blinding as it's been done in the past? What is the size of the trial that I just referenced? How confident can we be? Are there conflicts of interest in those conducting the studies? Are there other design or execution details in that evidence? And then the third thing is relevance. If you conduct a study on 4,200 white males between the ages of 40 and 50, maybe is or maybe it isn't applicable to a population as diverse as the Oregon Health Plan population that includes people of different genders, different ages, different social circumstances, et cetera. Is the population have the exact same diagnosis, or is it a slightly different constellation of people who is excluded from the trial? Are the comparator and the alternatives, is the comparator in the trial similar to the alternatives available to our patient? That can also change what the data needs. And then finally, how important are the outcomes to the patient and the population? Is this an outcome that matters to people experiencing the condition? Or does it reasonably predict something that matters? I'm sorry, go ahead.
Just one addition under evidence source. It's kind of relevance to the population is one thing, but evidence patients can also be a source of evidence, because as we saw in the EDS discussion.
Thank you. Yes, patient experience is a form of evidence, right? And it's a different form, right? It has a different perspective. Thank you.
And we might
Might need
call
to
it
call that
values and
out.
preferences, not sure. Another way to think about those top three boxes, in the report we get presented by the Center for Evidence-Based Policy, the top three boxes will be summed up as a certainty of evidence.
Right.
So you'll have some benefit or some harm-related outcome, and there'll be a certainty of evidence attached to it. The certainty of evidence rating is derived from all the things in the top three boxes.
Would claims data, where would that fit in under evidence source also?
Again, all of that is going to be reflected in certainty of evidence, and it's going to depend on the topic and how good the study is, and et cetera, et cetera. There are a lot of nuances. I'm just making the point that the top three boxes are going to come to our committee already kind of distilled through the evidence review process, which is done for us by the center.
Right.
So we want to be aware of those, like kind of what's the sausage making process of the evidence review and the certainty of evidence ratings, but that's kind of arriving at our committee, kind of already done in a way. And we can always quibble on some of those things, but theoretically we wouldn't have to do that determination ourselves.
Right, and the staff is hopefully doing this for you, and this is, you can go into a 6-inch level, or you can go into 100 feet level of an evidence review. We have limited resources, and we need to allocate those.
Is it worth mentioning though that this evidence source is from published,
This is the published-
peer-reviewed evidence?
Yeah, what we're talking about.
Manufacturer bringing in the claims registry is not.
Yeah, that's a good point, Liz. Thank you. I thought about mentioning that. This is evidence, I'm thinking here, and maybe we need to make that more clear, of the journal articles, basically, that we are including in the packet. Those aren't the only information sources.
Published, peer-reviewed.
Published, peer-reviewed.
Or
evidence.
evaluating public, because it's a lot, it'd be long.
Yeah. So this is published evidence, the kind of stuff we include in the meeting packets. All of that is distilled as Devin said, into the level of confidence in the evidence, but then there can be multiple outcomes. Something can improve pain, but also cause bleeding and cardiac arrest. And you need to do the balance of benefits and harms. So that is more of a human judgment and a little more subjective. And depending on your confidence in the evidence about benefits or harms, it may weigh more or less. So you can see the scale there. Sometimes after you've reviewed all this stuff, it's clear the benefits outweigh the harms, or it's clear the harms outweigh the benefits, and we can make a fairly straightforward decision and move on to the next item. Other times, we're still unsure, and we have another slide about that. Before we go there, any more questions about that slide?
So we always hope we're done after this slide, but we never are, which is why we're having this discussion.
All right, so these are some of the other factors, and I selected these. I think they all align in one way or another with the evidence to decision framework. Some of the linkages are more direct, and some of them are just more contextualized to our context because we're making coverage decisions, not clinical guidelines. We have the limitations of the billing codes, et cetera. We're not making policy for a clinic. We're doing coverage policy for health plans. We have our own norms and histories and tradition here. So trying to simplify and contextualize these. Again, equity, you see in orange there along the left side all the way through, but there's three main areas: evidence context, and again, that gets to the certainty. What are the alternatives? Reasons for limited research. So is it because it's children and it's hard to research children ethically? Is it because it's a condition that's doesn't have any attention because of economic injustices? Is it no research because somebody doesn't want to know how it works because they like the status quo? All of those I've heard discussed in this room. Values and preferences. What do patients and providers prefer? So we heard some pretty strong ones on the understand those. And why do they prefer it? What is the basis for that preference? How is the service viewed by policymakers and the public? That also comes into play. Do other payers cover it? That's sort of a barometer for both of those previous items, as well as just concerns about cost, right? That payers tend to pay more attention when it's costly. Is there a limited resource? A blood-based product or a placenta-based product versus a medicine that can be produced at scale. Is any related cost justified? Does the cost justify the benefit? Now, there are limitations legally on that, but again, where the cost is not likely to justify the benefit, we're going to apply more scrutiny in this group generally. How will use of the product or service change because of the policy? And we heard some uncertainty about that in our last discussion. What will be the impact of the decision we make? Could it displace a better service for the condition? Might it be offered as a low-cost alternative when the high-cost option is really what the patient needs? Or, that could cut a number of different ways. That's just one example. So those are some of the things and this was reviewed by our team, which made some edits, I think. So that's kind of how I distilled it. I'm interested in hearing how this lands with you, how what Marcus said might intersect with that, whether this kind of a tool is even useful to have as a resource for you all in making these decisions.
I'll just say off the bat that one of the things that it may be related to resources that we've talked about in the past, often comes up that you may probably want to list is how many people are potentially affected by the decision. So, essentially, we get to the second slide, and this is all, again, if we stop at the first slide, benefits, harms, there's a clear imbalance one way or the other. It's easy, relatively speaking. This is the hard part. So we're talking about making educated guess, and when is it okay to err on the side of coverage, and when is it okay to err on the side of non-coverage? What are the situations in which those things are are true, and can we like create some consistency across our educated guesses, so we're kind of guessing in the same way. Chris, go ahead.
Thank you. I think what's been my guiding light since I joined this body is I think a lot about that prioritization methodology. And I wonder if it's not a place for us to merge some of those features with this so that we can be consistent. I think there is a place for it. I think the piece that we're asked to change the way we think, and I don't know if this is the right place for it, because I'm feeling like what we ask our evidence-based partners to do with literature is one thing, but what we can get out of it, we could do more to get some of that personal, some of the people part of it, like what you were saying, how big is the problem? My other question is there populations that is disproportionately affected? Are they a vulnerable population? Are some of the things that I see coming up for the evidence and context? But I'm wondering, I guess the question to the team there is, the prioritization technically is going to go away, but is there anything that would be of use from that methodology that existed before that we could also bring to bear on these other ways of making decisions?
Yeah, that's an interesting point, just to keep it with a similar framework of thinking, not using it for prioritization, but the similar principles might apply. So we'd have to pull up that list. But there was something else buried in your comment there, Chris, which had to do with another thing that I think we have been discussing, which is trying to get Oregon-specific data to answer some of these questions. You know, how many people are affected, which groups are disproportionately affected, you know, that kind of thing in the state in which we're serving. And so I think we're trying to inquire about doing some of that.
Yeah, there is a whole body of that. I mean, that the OHA does a great job with metrics, so it feels like that could be a piece that would be part of and in terms of equity, like I think centering on people and giving a larger voice besides just the literature. If we're looking at a bigger model than just the literature review, then actually looking at having their voices heard. So like the listening sessions, I'd like to see weighted in on this. Or, you know, like most boards have to have part of their members as the board. So where's their voice here? Like, how do we incorporate the members that are receiving the services? Because they're lived, and so I guess for me, like that's separate than what I see as evidence from the literature, but it is really centered on the equity of the experience of our members. And how do we bring that into our process?
Yeah, so I wonder if there's, so, I mean, we did reach out to OHA just recently about trying to see if there's a way to, you know, join forces on, you know, data analysis to help with some of what you're talking about. But there's also the notion of, for the values and preferences column, maybe we want to start listing what the sources of values and preferences information might be, which has typically been public comments and testimony, but maybe there are other ways of gathering that information, and you know, we can brainstorm around that, and maybe folks have ideas around that. Stacy has her hand raised.
Just before we go there, Stacy, I think part of what I may be hearing from Chris is, can we put public testimony as an information source in addition to the evidence somewhere explicitly on the slide? Is that part of what you're saying? Just recognize that it exists.
Yeah, for values and preferences, right? I mean, how do we get at values and preferences?
I would see it would fit in values and preferences in the context of evidence. Then we can ask from there, that would be the claims data. So we end up knowing like what is actually really happening with the population that we're serving.
Yeah. Yeah, I agree with you there, but yeah, I think that's a useful, you know, maybe there's probably utility, not now, but at some point to have a page just on values and preferences. And how do we want to understand values and preferences, which I don't think anybody really understands how to do, quite frankly, in the kind of guideline world, but you know, you know, we may be able to do it better than we do it now. Stacy?
Yeah.
So I was just listening to this, and forgive me if this is included on the previous slide, Jason, that you showed us, but thinking as a clinician in the context of oral health and what happens for the state of Oregon in terms of costs when oral health isn't covered, many patients end up in intensive care units, and the cost of delivering care is far more expensive. So I'm wondering if there could be some kind of economic measure of harm for patients who are not receiving various types of interventions, where there's low evidence, we don't have really great standardized trials, but the topic comes up. If we can go and partner with other hospital systems or insurance claim data, just to ascertain what's happening when these people aren't receiving care, what that means for the state of Oregon from an economic standpoint.
So I'm hearing that again as a call for us to see what can happen with you know, kind of real Oregon data and what's actually possible. Larry?
Yeah, just real quick. I followed the link that Chris put in the chat, and I'm looking at the two examples. One is schizophrenic disorders, the other is grade 1 sprains of joints and muscles. And I'm looking at the total score for the sprains, and I'm thinking, if that were changed to people with Ehlers-Danlos, the score would be significantly different.
I sent it the link to the prioritized methodology.
Right.
I just sent it to you, Larry.
All right, fair enough. We're gonna have to wrap up here in a few minutes. Other factors that we want to consider here.
Just a general idea of if we can have other funds or resources to address some of these. I mean, we have the Center for Evidence-Based Policy to help us in that purview, but I'm wondering if to work on our goal of equity considerations in everything we do, if we can have access to an expert center that can do research on Oregon-specific information that maybe could answer some of these questions.
I'm hearing
love
a
that.
consensus around Oregon data. So again, I mean, we did just last week, we sent OHA an email exactly about trying to figure out what kind of data capabilities we could bring to bear, you know, that's.
Yeah, and just asking a different organization with a different thought process might be able to come up with things that or angle it differently than we would.
Yeah, and I mean, I particularly for the equity thing, right? In my view, it's really hard to think about equity if you don't measure where the disparities are. So you gotta,
and see how our policy
for the data has to kind of drive, you know, what we're looking at, because you can define it as rural disparities or, you know, different racial and ethnic groups or however, but you know, you have to know what's actually happening on the ground. So, yeah, so I hear that, you know, everybody's kind of interested in this idea of, you know, Oregon-centric data, which we're going to be beholden to what's actually possible to do with resources and the data available. But all right, we're going to have to wrap up here in 2 minutes. So any burning last comments?
Yeah,
or
I'll
questions?
just say, if you have thoughts you weren't able to share today, this would be a great thing to email me or even set up a meeting to discuss, because I think this will become increasingly important as we look at the unfunded region. So some things that are there because of reasons that relate to these, and hopefully we can be making consistent decisions. This gets back to what you said about it's not a mission statement exactly, but it is about consistent methods and practices. And so really appreciate any wisdom or thoughts or resources you all are aware of as we do this. And that includes you all in the public who may watch.
I really like the idea of working to make the data more real to life and also to improve, to have an increasingly standardized and consistent process. I also really like what Stacy said about factoring in economic harm. I think that's important.
All right, good discussion. As always, lots to think about and wrestle with. Awesome. Well, with that, we will bring the meeting to a close, and the next one is happening
November 14th, same place, online and in this very room.
and I won't be here.
Devin will not be here. Anybody else? Lisa will not be here. Anybody else who cannot attend? Please let us know. Jessica's going to send out an email, but thank you for those of you who just let us know.
Does that mean I'm chairing?
That means you're chairing, so
Okay.
you'll be here. The answer is yes.
Thanks, everybody. Great discussion. Appreciate it.
Thank you. Have a good day.
Thanks, everyone.
Bye.